You have start screen sharing. So what am I?
Do I hit go to application?
So don't worry about it, Professor Seth. We'll just muting you for a minute. We'll play your recorded video and then unmute you at the end of the video and get your screen, you on main screen for discussion.
Yeah, I'm on muted.
Put it off.
You have me muted.
Yeah. So good morning, everyone. What a start to a technology thing. We just saw human navigation. We saw the perils and the benefits of being able to communicate seamlessly and yet achieving a part of it. So it's a good start. Well begun is half done. It's my pleasure to introduce and to welcome the chairperson for this session, Dr. Ashok Rajgopal and Professor Wolfgang Kleiser. They are both here. And the first talk is, of course, by Professor Seth. So it's a recorded video and it's an interactive session. Please feel free to ask questions. We have kept a good amount of time so that people can interact well. So over to you, chairpersons. Thank you.
Thank you, Vaibhav. Good morning, gentlemen. Good morning, Wolfgang. It's my great pleasure to welcome you all, and we'll have a wonderful session of the Wisdom Studio. Each speaker in this is a master of his game, and what better way to start this morning than have one of the doyens of the arthroplasty world, Dr. Seth Greenwald from Cleveland, and he's going to be talking to us about uncemented TK, where are we in 2024. Can we start the presentation, please?
Good morning, ladies and gentlemen. My name is Dr. A. Seth Greenwald, and I have the privilege of speaking to you from Orthopaedic Research Laboratories in Cleveland, Ohio, in the United States, far across the oceans and continents. The purpose of this presentation is to speak to the title overview of where we are in 2024 regarding cementless Good morning, ladies and gentlemen. My name is Dr. A. Seth Greenwald, and I have the privilege of speaking to you from Orthopaedic Research Laboratories in Cleveland, Ohio, in the United States, far across the oceans and continents. The purpose of this presentation is to speak to the title and provide a brief overview of where we are in 2024 regarding cementless component fixation in total knee arthroplasty. The successful employ of total knee arthroplasty is appreciated by the more than 1 million primary TKA procedures performed in the United States annually in 2022, with cementless tibial and femoral component fixation being utilized in approximately 17%, a number that continues to increase on an annual basis. Beyond the relief of pain and restoration to a functional range of motion, the goals of total knee arthroplasty include achieving appropriate limb alignment, long-term stability, and a secure fixed prosthesis to short, medium, and long-term exposures. The achievement of these goals with existing or advancing technologies is dependent upon a performance triad of design, materials, and manufacturing choices, patient factors, and surgical variables, inclusive of small soft tissue interruption and repair, bone resection, component selection, and placement, all of which contribute to the in vivo integrity of a total knee design. Successful long-term cementless TKA outcomes require a stable prosthesis-bone interface in the immediate postoperative time frame. To promote osteogenesis, close contact between the implant surface and surrounding bone should be such to minimize micromotion. In addition, good bone quality is required in addition to precise preparation of the bone surfaces. This biologic process is directly influenced by component variables, including the substrate material, the porous coating material, the pore size, diameter, and morphology, in addition to the overall implant geometry, and patient variables are inclusive of younger, active, and obese individuals who demonstrate good bone quality. Encouraging short-term, early clinical reports promoting cementless fixation designs first appeared in the 1980s. However, as in vivo time progressed, the histologic studies of retrieved cementless knees observed bone ingrowth in the porous surfaces of femoral components, while tibial base plates displayed fibrous tissue between the implant and bone with little bone ingrowth. These findings implied the presence of micromotion at the tibial base plate bone interface, and it was determined that a central stem and/or screws were required to achieve good initial component fit. As time in vivo increased, high short-term reported failure rates for metal back patella components was predominantly due to polyethylene wear through, and/or fracture in conjunction with poor trochlear groove design on the femoral component. Osteolysis as a result of increased polyethylene wear was now occurring in association with cementless total knee arthroplasty, and the predominant reasons included the use of thinner polyethylene and the relatively flat articular surfaces. While the inclusion of screws for improved component fixation, the modular stem length, and the incomplete or porous patch coating on the distal tibial base plate provided pathways for polyethylene wear particles to migrate from the joint space to opposing bony regions, as described. While experiencing these early setbacks, predominantly due to design and material variables, cementless fixation and total knee arthroplasty has clearly demonstrated clinical success in the long term when patient, device, and surgical technique are optimized. And these, in fact, led these authors to conclude that cementless fixation was comparable to cemented fixation at long-term follow-up. To reduce polyethylene wear and fracture, polymer iterations were developed which appreciate the role of increased cross-linking while minimizing oxidative degradation. These processes include heating above or below the melt temperature, the source of radiation being electron beam or gamma, a radiation dose level generally from 0.5 to 2.5 megarads, sequence of application, endpoint sterilization, and antioxidant inclusions. The one common factor of all of these polymer iterations is that irradiation is now part of the manufacturing process. Further, cementless component fixation has also been advanced through the utilization of hydroxyapatite coatings to accelerate bony ingrowth, through plasma spray coatings as an alternative to sintered beads or to fusion bonded metal ingrowth surfaces, and continually evolving porous metal technologies that claim enhanced fixation through the provision of three-dimensional ingrowth matrices, an increased coefficient of friction between adjacent bone and the interosseal surface of the implant, increased porosity, and reduced stiffness to better align with structural rigidity of cancellous bone. Further, short to mid-term clinical studies utilizing contemporary cementless total knee arthroplasty designs are reporting outcomes equivalent, if not superior, to those of cemented fixation in younger and obese patient populations. The reported advantages of cementless TKA include reduced OR time by eliminating cement mixing and setting, reducing the need for tourniquet use, enduring osteogenic fixation in obese patients less than 65 years of age, highlighting the use of cement for osteoporotic and older patients, the latter serving as a contraindication for the use of cementless devices. At the end of the day, early clinical experiences with cementless TKA demonstrated design, material, and surgical technique shortcomings that required optimization. Contemporary manufacturing technologies allow for optimal surface morphologies, 3D ingrowth matrices, increased porosity, reduced structural stiffness, and increased frictional fixation. Component placement and bone preparation assured through navigation and robotics continue to contribute to enduring outcomes. In mid to long-term survivorship reports, cementless TKA is equivalent to cemented fixation and is rapidly becoming the recommendation for young and obese patients with good bone quality. Thank you.
Thank you, Seth. Always, a very eloquent
Good morning,
presentation.
ladies and gentlemen. My name is Dr.
Can you
Seth Greenwald,
Can you
and I have
stop
the
that?
privilege of speaking to
Can
you
you stop
from
it?
Orthopaedic Research Laboratories in Cleveland,
Stop the
Ohio, in the
presentation,
United
please.
States,
It's done.
far across the oceans and continents.
Right. So the floor is open. Are there any questions to Professor Seth Greenwald? So how many people in the audience, both from India and overseas, have experience with the cementless? No? Yes, Wolfgang, do you want to make some comments or ask any questions?
No, I think I just wanted to highlight the fact that I think that this is going to be the future. I think it was a very good presentation. Thank you very much for that. I think there is economical issues there involved as well. So my concern would be for the broad amount of patients that we're now seeing, especially the younger generation that are increasing in our patients' population. I would be concerned with respect to the economical aspects. What do you think about that? I mean, it's going to get more expensive, isn't it, if we use cementless TKA?
Seth, you're muted. Can you unmute?
Okay, I'm on.
Yeah, you need to unmute
Can you
yourself.
hear me? Can you hear me now?
Yes, yes.
Fine. Well, let me make a few comments in that regard. It is true that the cost of obtaining a femoral and tibial component that they predominantly recommended for cementless fixation have about a 10 to 20% cost override over that with pure cemented technology. But I have to point out to you that it's almost like a simile of repetition. If you recognize the fact that when total hip arthroplasty had its beginnings, beginning with John Charnley in 1962, we went from cemented to cementless, and now cementless dominates a large portion of the primary total hip replacements that are done in the United States. And I suspect slowly but surely, particularly perhaps aided and abetted by both navigation and robotic availability, that this increase will continue. We're up to about 17% per year in terms of total primaries done, 17% of which are cementless. And that number has consistently increased by a couple of percent each year. Mind you, it does require, as I indicated, good precise fit between the anosteal surface of bone and the outer surface of the implant. Once that initial stability is assured over a 0 to 6 week period, ingrowth can occur, particularly on the tibial surface. It's interesting to note that when these first began back in the 80s, bone was always really obtained on the femoral component, but because of the micromotion that occurred on the tibial insert and bone, fibrous tissue ensued. But as time goes by, that is becoming overcome. And I'd hasten to say that I'm not quite sure in the end, cementless will dominate the use of primary knee replacement as we have witnessed in the hip. But I do think it is a viable option for a large number of patients, particularly younger ones with good bone quality, since we have now overcome the short and long-term difficulties in the wear of articulating surfaces, particularly plastic and metal.
Thank you, Seth. I would absolutely echo that sentiment. I grew up doing cementless. Started with the Freeman Samuelson, and some of the knees we did almost 28 years ago, including an uncemented all poly tibia, still going strong, almost 28, 29 years down the line. We then graduated onto the Miller Galante 1 and 2, and you're absolutely right. The failures happen not from failure of fixation, but because of the thin, flat-on-flat poly and the screw hole osteolysis that sort of ate up into the cancellous bone below. We then graduated onto the TM uncemented, and I have to concede that we have almost at 12 years or 13 years, we have almost 98% survivorship. So I think everything you said is pointing in the right direction. The numbers of cementless interventions is going to increase. It's an exacting and technically demanding surgical procedure, and obviously the cost factors do kick in. But overall, like you said, I think this is a very balanced view that it may not overtake cemented, but it is certainly going to be a very viable option for surgeons in the future. Any other comments? Yeah.
Seth, now with increasing use of robotics, we try to do different kind of alignments where the tibia is in various degrees of varus and the same thing is in femur. You think this uncemented implants, would there be any effect on this kind of alignment, or it would really not matter?
Well, no, alignment is one of the sine qua non factors that has to be achieved, whether you use mechanical alignment or not. I think I would put the question back to you in India. What is the greatest incidence of knee pathologies that you see? Is it the varus patient? Is that where you have a large number of
varus patients?
So yeah. And how do you correct for that? You correct the varus. I mean, there are different alignment techniques, but tried and true mechanical alignment will get you there. I think all the time. I do think I would agree with Professor Rajapal that we will see increasing uses of cementless devices. And I think it's very, very important to recognize that a good appositional fit, particularly on the tibial surface, has to be achieved. It's interesting to note, and I think this is worthwhile commenting, that the surfaces of these cementless implants demonstrate a 70 to 80% porosity, which means that they, as long as you obtain a stable interface, it's really a pathway for the whole osteogenic process to occur. Blood vessels, callus, and bone formation, so long as you have stability at that interface.
Thank you.
Thank you, Seth. On that note, I'd like to thank you. I know it's late in the evening for you, and really appreciate your being available to us. You know, the years of experience and wisdom, and thank you once again, Seth, on behalf of all of us in the organizing and the audience here. Let's give him a big round of applause. Thank you, Seth.
Thank you. Have a good meeting, and I welcome your day. Bye-bye.
Bye.
Bye-bye. So we're going to continue with our program. I would like to ask Professor Sostam to actually come up, give us a talk about tribology for hips. What's up there? room for innovation.
So it's difficult with the two Michaels. I just get the other Michael's talk now. Switch the computers. Yesterday. Well, I can give it to you again if you want. So I'm going to start with a little video I just came across a couple of years ago, if it works. Can you start the video?
See you again. Cheers. Anything else? Excuse me, madam. This might do the trick.
Oh. At Caltex, our staff will do whatever they can Thank you so much.
You're welcome.
to help make your life a little easier. Caltex, nice and easy.
So let's talk about tribology for hips. You know, I come from Munich. The famous FC Bayern plays in the Allianz Arena. Although they're not playing really well right now, they finally won a game yesterday, but the malpractice might be a topic for the newspapers, it's not a topic for this conference. But why do I say that? Because those guys usually truly use their joints. And that's a guy I just did last week, 43 years old, bilateral hip, professional sports player. Used the spinal stem because I wanted to survive. And our challenge are the young active patients, and they do have a higher tribological demand. And we know the revision rate is a little different for this group of patients. But if you look at the revisions, loosening, and that's out of the German arthroplasty register, loosening is still one of the top causes of revisions. And why do we have that? Because of wear. And I don't have to explain you how wear works and leads to osteolysis. You guys all know that. But we want a long survivorship, and we want a perfect function. And how we usually increase the function in hips is with head size. We get a better range of motion and stability. And we know data that showed that the 36 millimeter head has a higher wear compared to the smaller things, but that's for metal heads on poly. That's not true for the ceramic heads. And with the metal heads, especially for the 36 millimeter heads, we had the problem with trunnionisis, and we had to revise many stems because of a severe damage on the taper. If we look at the German arthroplasty register again, we see that we really try to use 36 or 32, probably the 28 millimeters are just the really small cups. You compare wear with the different materials, different bearings, we know that metal on poly has the highest wear, while ceramic on ceramic has definitely less wear. And again, German arthroplasty register data from the last year, we see that our standard in Germany is ceramic on highly cross-linked PE, and the metal heads almost disappeared. But that's not true for the other countries. There's a real global diversity on that topic. If you look into the Scandinavian countries, they do lots of metal on poly. And if you look at Australia or South Korea, there's a lot of ceramic and ceramic, and it even made it into a commercial. If you look at revision rates in the different registries, metal on poly, metal on metal have the highest rates of revision, while the others are almost the same. So if we look at ceramic on ceramic, it has the lowest wear of all. It has excellent chemical stability, excellent lubrication, high biocompatibility, and you don't have any problems with the larger heads. But you do have the squeaking, and it really appears. You have impingement, and although rare, we do have fractures of head and liners, and of course it's more expensive, and that might be the main reason why Germany doesn't have those high numbers. Reasons for noises, it's multifactorial. It might be malpositioning, impingement, high BMI, or even leg shortening. But if you compare the different bearings, and this is a study out of the German Journal of Arthroplasty, compared ceramic on ceramic and ceramic on polyethylene, there was no difference in survivorship. And I'm going to show you a different study here. 100 patients, 200 hips, so bilateral hips, and one side was done ceramic on ceramic, and the other side was done ceramic on poly. And the data showed no difference, with a long follow-up of 12 years, no difference in clinical and radiographic results. So why do it more complex if you can get the same results cheaper and easier? If you look at other options, for example, for the Pinnacle Cup, there's the Ultrax polyethylene, where they just use a different dose for the irradiation, and they could achieve a lower wear, almost compared to ceramic, so ceramic by 50%, but again, higher costs. So although we've come a long way, we're still not done. We still have loosening, fretting, trunionosis, wear, infection, and there's a true need for innovation and further investigations. Maybe nanotechnology might come up with different materials. Biomimicry in terms of lubrication is a really important field. And what if we can finally coat our implants, for example, with an antibiotic to prevent infection? Thank you.
Thank you very much for this very nice overview. Are there any questions from the audience? Just a question from my side. You were mentioning the highly crossing polys. What about the vitamin E enriched polys? Do you think that's going to even improve the results even further?
We've seen data that there's only quite a small improvement, but again, with the vitamin E, we do have a higher cost, and that might be a reason why it's not used or spread wide used.
Okay, so and also long-term data, according to my information, is still missing out there, yeah. Okay, how many of the audience are using ceramic on ceramic here? Ceramic on ceramic, so quite a few numbers, okay. After this presentation,
And what comes out of the various registries.
yeah, one of the interesting points is that the US are still doing a lot of metal on poly. That's what I always find fascinating. They are talking about so many new technologies, and then they're still using metal on poly, which is amazing.
So first of all, thank you very much once again for having me here. And I would also like to thank Michael for stealing my thunder, because he shown quite a lot of slides from the registers. And just correcting Wolfgang, I think 80% of the femoral heads now in the US are ceramic. The date of this year, yeah. So let's get started. So what about registry and the current status? So let's start with a little cartoon. You know, this is a problem. This is a problem for registers as well, because if you amputate an above knee, then the registers don't pick that up, and your knee is still a success. So just be aware of that. If you can't measure it, you can't improve it. And I would urge everybody in the room to make sure that if they make some changes to their practice, that they measure the outcome for the patients. So conflicts of interest not relevant for the talk. Let's talk about registers. So first of all, register comes from the Latin word registrum, and that's things recorded. So register is a file of data related to population base, and that's the actual document. Registry is a system of ongoing registrations, and I know they're mixed up continuously. So whether you call the National Joint Registry and the Swedish Register, it doesn't really matter. So they just mean the same. So they go back to birth registers and death registers and disease registers, all started in the 16th and the 17th century. So what type of registers do you have? You have causes of death, birth, delivery of healthcare, hospital discharges, population characteristics. You got disease registers, you got reimbursement registers, and you got quality registers in Sweden. And Sweden is one of the starting countries about registers, and they've got more than 100 quality registers measuring anything from Parkinson's to diabetes to total hip replacement, total knee replacement, ACLs, spines, everything. And if you then start linking different, oops. If you then start linking registers, then the opportunities are really massively. So that's what I've been involved in linking registers to look at. Yeah, that's fine. That's fine. Looking at outcomes, longitudinal outcomes for hip replacements. So there is also a link with Codman. So Codman from the States started the registers in Harvard, and his idea was looking at the end result ID. So every hospital should follow every patient they treat long enough to determine whether or not the treatment has been successful. And if it isn't successful, why isn't it successful, in order to prevent similar failures in the future. So the Harris Joint Registry was one of the first registers that then looked at their joint replacements together with the Mayo Clinic. And this has been recognized. The Kappa Delta Award from the American Academy was awarded to Henrik Malko and the groups around him. So Dan Berry from Mayo, Bill Harris from Massachusetts, Otto Robertson from Sweden, Johan from Sweden, David Llewellyn. So they all were awarded a lifetime award for their work on registers. So what is the aim? The aim of registers is analyzing healthcare institutions, their activities, stimulating continuous clinical improvement of care, research, post-market surveilling, hypothesis generating for the RCTs that will be discussed with Mohit Bhandari. And nowadays we do register nested RCTs as well. So what you can see is what is the real world data, instead of just an RCT where you just have a little bit of a limitation of some selected patients. So who's the registers for? Patients, surgeons, departments and hospitals, healthcare providers and groups, countries and government organizations, and the international community. But also we know that using registered data, you can improve healthcare's value. And I'm a little bit involved in value-based healthcare, and what I've seen is that using the registers in the Scandinavian countries, they were able to reduce the revision rate quite a bit. And if they would do the same thing in the States, or if they would have done the same thing in the States, they would have had 8% cost savings on the orthopedic budget. So you can adopt best clinical practices. We can talk about approaches in hip fracture surgery or using cement in hip fracture surgery, limitation of number of implants, and stepwise introduction of technology and implants. And going back to Henrik Malko. So value-based healthcare and registers, agreed outcome measurement sets. So we need to make sure that the prompts can talk to each other. Transparent and accurate recording. So what you measure is what you really need to measure. reliable and timely communication, dissemination of outcomes, and I think we're getting better in this. The reports are getting earlier. The data is also getting better as well. And we really need to measure what is important for our patients. And if you measure all of this, what you can see is that nobody wants to be the last in the class. So we all want to be the best surgeons in the world, or if you look at it in a British way, getting it right the first time. So my involvement in the registers was my thesis, a couple of publications, and looking at the pathway of hip replacements. And then I've already mentioned this before on my presentation, I think on Friday, looking at a stepwise introduction of new technology, the next level of dilemmas. So are we doing it right, introducing robots and new techniques and new technologies, or are we doing it wrong? Because we've failed the patients before by introducing metal on high scale and seeing that it wasn't really as good as it used to do. So Henrik, Henrik has really been involved in registers quite a bit, and he started with his thesis, which took him 10 years to write, but I think it's one of the most quoted theses in the world. And then he talked about innovation, and then the next critical role of orthopedic registers, looking at register-nested RCTs. But now we're in a technology meeting, so what do registers tell us about technology? I think long-term outcomes of technologies are still missing. In the NGR, there's absolutely no data, as robotic is no part of the MDS. It's only this year, of the last set of MDS, minimal data sets, that we now have to fill in whether or not we use navigation or robotics. In the Australian register, there is some recordings of computer navigation, robotics, and patient-specific implants. And there are some publications, so there's two publications there. Use of computer navigation in total hip replacement is associated with a reduced rate of revision for dislocation. And if you use robots for unis, your outcomes are better. However, in this year's report, and I've highlighted in yellow, they say that the use of computer navigation and robotic assistance doesn't lead to improved outcomes, both in hips or in knees. But what are really saying? So this is from this year's report. You can see, so for unicompartmental, you can see that there is an increase in usage of technology assistance, but you can also see that on the bottom here, that is diverging, and the confidence intervals are not crossing over, and the p-value is less than 0.05, so there is a difference if you use robotics or technology for your unis, so there is a difference. So what about total knee replacements? So on the left-hand slide, you can see what's happening with regards to the Australian surgeons, whether they use technology or not. So there is certainly an increase in use in technology. The robots are the green line, so they're increasing. But if you look at the outcome between computer-navigated and non-technology, there's absolutely no difference. So you can see the p-values are higher than 0.05. The confidence intervals are overlapping. So we can't really say that robots, navigation makes a difference. And what about robots now? So blue line, no technology, green line, robotics. And you can see, despite the fact that the p-value is not statistically significant, or doesn't show statistical significance, is that they're diverging and the confidence intervals are not overlapping. So at 5 years, there might well be a difference. But maybe it's a little bit too early, and we don't know what's happening, whether this line is going to go crossing, and if it's crossing, then certainly they will be right, and the registers will say that maybe robotics is not really the way forward. So we talk about technologies. What about techniques? Well, I could go into detail, but we know that the registers sorted the problem out of metal on metal. It's also reiterating the fact that the use of cement in hip fracture surgery is the way forward. There's now more and more evidence from the Australian registry that patella use should be promoted, or replacing the patella in total knee replacement should be promoted. 6.6% of their revisions in Australia are for secondary replacing the patella, and there's an increase in no patella usage in Australia. Approach in total hip replacements, we had some nice lectures on direct anterior approach, direct lateral approach. There is a difference in approaches. However, the outcomes for patients, whether you use a DAA or a posterolateral, the PROMS data after 1 year is the same. New implants, we all know about new implants. The Australian Registry and now Kaiser Permanente have said that newer implants do not really improve the outcomes for patients. And head size, which has already been alluded to by Michael in the previous talk, we're talking, we know that the bigger the head size, the better. So In detail, arthroplasty for hip fracture surgery. So we know from registered data, uncemented implants to be avoided, posterior approach completely to be avoided if you do a hemiarthroplasty, small heads to be avoided. And if you really decide to do total hip replacement in neurological challenged patients, you will have a problem. So what is uncertain as on the basis of registers, the role of total hip replacements and the role of dual mobility components is still uncertain, although there is some evidence that it might be worthwhile considering. And that's where RCTs are coming in place, the RCT of Mohit Bhandari and the new RCT in Holland, as well in Sweden, where they will compare the use of dual mobility cup versus the traditional bearings. So what about the future of registers? So there needs to be national interest in the work and the function of registers, and it's always increasing. There's always room for improvement in registers. You know, the data quality is something that is sometimes the Achilles tendon of the register. So data quality must be very good. Buy-in from the professional organizations like in Britain, the Hip Society and the Knee Society, using the data to guide their surgeons. Register nested RCTs, the future, international cooperation, looking at signals for failing implants if they haven't been used a lot in different countries. Just combining all the data in one register might help. There is a symbiosis between registers and value-based healthcare to make sure that the value of the healthcare that we provide keeps on being affordable. Use for evaluating technology and dashboards which give an immediately return to the surgeons to see how they're doing. So the past is the key to the future, and I think we talked about technology and techniques here, but don't forget the past. Make sure that we learn out of our mistakes and we just improve the care for the patients. So in conclusion, registers, a robust wealth of data, providing additional information to support evidence-based practice, feedback and information for the four stakeholders, the patients, the surgeons and their professional bodies, the hospitals and the healthcare providers, and governmental organizations. You need to be aware of the limitations of registers, but I do believe there is some bright future for registers, and the role of technology should be evaluated within the registers as soon as possible. So next year in this meeting, we can just suggest what the evaluation of technology starts happening. Thank you.
Thank you, Peter. Great presentation. Any comments or questions from the audience? Would anyone like to? Yes, Weber.
So brilliant talk, Peter, as always. A very comprehensive overview. Could you just tell us all what has registry really told in last 5 years that has made a remarkable difference in the way you practiced 5 years back?
So, for me personally, or for the community?
Generally, personally, as well as generally. What do you think has world changed in last 5 years because of registry? We always talk about metal fiasco, but after that, what has really changed?
So I think if you look at hip fracture surgery, what has changed is the big drive to use cemented fixation on the stem in most patients, but specifically females over 70. And we can see that the return rate in the States now is that they're really picking up now and putting more and more cemented stems in because they've been faced with their own problems. So everybody says we don't have periprosthetic fractures, but the registered data came out and yes, you have got periprosthetic fractures. So they've all been warned now. And if you don't follow the guidelines, there will be some consequences for the patients and for their institutions as well.
There are different registries, in US, in Europe, and in Australia. Now, a single issue like patella resurfacing or not, would the data be captured equally, or there are different data in different registries? I mean, what happens? Would it be able to give us some guidelines? Because when we go through all the registries, again, the data is confusing.
I completely agree, and that's why you need to look at registers with very good quality. So whilst the US register is one of the biggest, their data quality might not be the greatest. So if a patient gets revised outside the Medicare, Medicaid, it might not be picked up. So the Australian register has got good quality on both primaries as well as revisions. And from their data, they say that patellas should be resurfaced because 6.6% of their revisions are secondary patellar resurfacings. And you are aware from your, well, I'm not sure whether you're aware, but from clinical practice, 50% of these operations are a failure. So 1 in 2 patients that you do a secondary patellar resurfacing don't do well. But do we have to resurface every patella on the base of the registers? No, because if you do that, you will replace patellas that might not be replaceable. So just be careful. You still have to have your own clinical expertise when you operate. If they're too thin, then please don't start replacing patellas, because you're going to have a patella fracture, which is a massive complication for patients.
Thank you, Peter. Just on that note, we have a organization of the Indian Society of Hip and Knee Surgeons, and we have been having our registry that's been up and running since 2007. So at our next meeting, we'd like to sort of present our findings with the registry. And I think this is a great insight into what's been happening over the years. It gives you the earliest red flags and cautions you in which direction arthroplasty needs to be going. So on that note, I'd like to thank you for the lovely presentation. Our next presentation is by Dr. Vikram Shah. Do we have his presentation, Dr. Vikram? Is he online? Yeah. So can we plug him in, please? Yeah.
Good morning, Ashok.
Hi, Vikram. Good morning, and lovely to see you and have you with us virtually. Next time, we'd love to see you here, but it's always such a pleasure to connect with you, and looking forward to hearing you, Vikram. The floor is yours.
Yeah.
Yes. And great to see you, Seth, as well.
I have not taken a pain to make slides.
Okay, that's fine. So you can just speak, and we're all ears. We are very, very eager and keen to hear you. And you've had such a wonderful journey with arthroplasty over the years. We'd love to share your insights about your journey so far.
So it is about art, science, and commerce. Nilan has asked me to talk on that.
Vikram, can you turn your video on? We're not able to see you. If you can turn on the video, then we can see you. And
Yep, there you go.
yeah. Now we can see you. That's great.
So it is about art, science, and commerce. I would put it, if commerce is concerned, art has the highest margin profitability wise, science has little less, and commodity has even less, and healthcare even has further less. So as far as commerce is concerned, healthcare is not a right business to do the business if you want to do business. But fortunately or unfortunately, we are all doctors, so we have to continue doing this only. Now about art. About art, I would put it in two parts: skill of surgery and clinical acumen. One of the meeting I was asked about evolution of a surgeon. When surgeon starts his journey from residency, he does outer brain surgery. He's thinking and operating. At times he's perspiring. At times he's asking assistant whether he's doing right or not. I call it S1. Then the next stage comes the surgery of a small brain, where he's doing it regularly. So he's not perspiring, but he can call for outer brain help anytime. He doesn't like anesthetist to talk with anybody. Then the third stage comes when he starts doing it daily. I call it S3, and the surgery comes at a spinal level. He is doing it effortlessly. He's not perspiring. He's not tired at the end of the surgery. And he can start music in the OT. He can enjoy surgery. But very, very few surgeons in their professional life reaches S4. And S4 is a place where surgery comes from spine to fingers, and it ceases to be science and becomes an art. So that is S4. So I call it S1, S2, S3, S4. From outer brain to small brain, from small brain to spinal reflex level, and from there to fingers, and it becomes an art where it is not only effortless, but it happens, he doesn't do it. Then the second part, I call it, is a clinical acumen. I put it in 4 parts again. Data and information. At a residency level, you are at a data and information level. With a continuous use of your information and data, what you have studied, what your experience is getting richer, ultimately you reach at the level of knowledge. You have enough knowledge to take right decision. That is, I call it C3. So data is C1, information is C2, C3 is knowledge, and beyond one level, you reach to the level of wisdom. That is, I call it C4. So surgeon's journey is from S and C 1 to 4. Not every surgeon reaches 3 or 4 level. If you are C3, S3, 4, then you will do very well. If you are C4, S3, 4, you will do great. You get more luckier as you travel the ladder, as they say. Minimum 5 years are required post-residency to achieve level 3, and minimum 10 years are required to achieve level 4. Very difficult to cross any level after 55. So it is important that you put your all efforts to cross these different levels in earlier age of life. Now, what this wisdom does to you is your decision making in a right and optimum way. I remember KTD, means KT Dolakia and me were attending one meeting in 96 in Ireland, and I just told him that why you are not doing your knees, why you are stick to total condylar. He told me, Vikram, I have burnt my fingers with isoelastic hips. So I have decided I will go with the implants which has given me result for 20 years. And he was so right that Kinemax Plus did not work as well as total condylar joints. Similarly, you have seen ASR, metal on metal, high flex knees, and all those things. We never touched those things at Shelby because we never wanted to take chances with our own patients. Now, I would like to talk about robotics as far as the science is concerned. From 2000 onwards, 5 generations of navigation and robotics have come. And what has happened? Number of surgeons have bought over the years, spent money after it, and they have neither increased their business nor it was useful. Having said this, last 5 years, these robots have changed a lot. And coming 5 years, they are going to change furthermore because of AI. It is going to give much better result than what it is giving now. Unfortunately, as on today, all these companies are selling all these robots as a marketing tool rather than any great use to surgeon. So be careful when you are buying out from your own pocket. Because when it comes to commerce of this, the commerce of this is net profit margin of healthcare is never more than 10%. And if you are not achieving 10 times growth of your business, you are not going to take out cost of the robot from your pocket. And it is going to become really useful when it can give result of C4, S4 surgeons look, feel and move in the hands during trial. When that robot can give, then the robot will be replaceable from the OT. Now, just 2 lines on commerce. We, almost all of us, live in democracies. And in democracy, healthcare is a holy cow. And holy cow is something you can't even milk that. As far as democracies are concerned, healthcare is controlled, regulated, and it is with the lesser margins. So if you have any other business to do that business, don't get into healthcare business. Thank you.
Thank you, Vikram. As always, a very, very thought-provoking presentation. Love your insights and your sharing your experiences with us. Are there any questions from the audience? Any comments? I want you to know that this presentation comes from almost about 35 years of innovation, growth, and Vikram, incidentally, is also the managing trustee of the Indian Hip and Knee Society, and apart from being a very dear friend, a very, very accomplished surgeon who has got a huge practice, a network of hospitals across India. And so I think each of these words that he made come out of a lot of years of experience. Yes, Nilan.
Vikram, thank you very much for being here. Now,
thank you.
One of the things that you said is that don't get into the healthcare business. After being a leader of the healthcare business, as Ashok said, for the last 30-35 years. So are you saying it to scare the other people? Or are you... and what have been your difficulties in the healthcare business that makes you say this?
See, the reality is, if you see all these big business houses, they create charitable hospitals. They don't get into healthcare business at all. Why they don't get into? Because it is holy cow. See, governments across democracies keep on changing rules, keep on changing reimbursement, keep on, they don't like healthcare to make money, and that comes in their eye first. They never regulate food prices. They never regulate any other thing which is required by the general population.
Right. And just your view on robotics, like even you must be sometimes having patients who say that, would you do this robotically? Or what is your answer?
My answer is I don't need it. People use it when they need it.
Thank you.
Excellent. Thank you very much for your insights. Having said that, I think we need to proceed with our program, and I would ask Dr. Grayeb to actually come up and talk about imageless robotics and key learnings. All the best. He's online. Oh, yeah, okay, I hear he's online. Okay, excellent. So, Dr. Grayeb, are you there?
Good morning, everybody.
Yeah, perfect.
My name is Francesco Falitz, and I'm pleased today to join this wonderful meeting, which I really sorry not to be able to participate personally, but I just came back from India 2 days ago. But I would like at this time to thank my good friends Ashok Rajagopal and Viva Bagaria to invitation to share with you some little thoughts about lateral uni knee replacement and share with you some tips and experience and outcomes of this kind of procedure. As we all know, valgus deformity and isolated lateral arthritis comes from a posterolateral meniscectomy or after post-trauma and osteotomy of the tibia, as well as osteonecrosis of the lateral condyle and sometimes following malposition total hip arthroplasty. Of course, based on this, the indication for unilateral replacement has to consider the possibility to not to have medial compartment integrity, no patellus pain, ACL integrity, passive range of motion over 90 degrees, flexion deformity lower than 10 degrees, as much as the deformity of the valgus less than 15 degrees, and a recovertum extension of less than 5 degrees. All this will give you the possibility to make a good choice when deciding to make a unicompartmental on the lateral side. Of course, based on anatomy that we have to consider, we have to remember the lateral tibial surface is different in shape and size from the medial, where of course medial is concave, large, and long, and instead the lateral is convex, small, and round, as you see in this anatomical specimen. Based on this, we have to remember that we have different indications and different behavior for this procedure. And I would like to share with you a case of a young man, 65 years of age, having a valgus after lateral meniscectomy, particularly visible on Rosenberg view and standing or long leg standing. And you see an MRI shows a significant involvement only of the lateral compartment, meanwhile all the other compartments were absolutely integral and no damages. When doing the approach, it's very important when doing a lateral uni compartmental total knee replacement to start incision on the lateral patellar edge, avoiding as much as possible a tendon split, in order to have the possibility to leave absolutely safe all the extensor mechanism. Then after the incisions, an arthrotomy is carried out in order to expose the joint and having a full view of the internal compartment and being able to expose the condyle and all the damages of the anatomy of this part of the knee. Of course, we have to remember that when we do perform a uni, we have to remember what bone landmarks to look at. When tibia and when positioning the knee, we have to remember the tibia is internal rotated because we have to have a medialization of the patella that of course will lead you to an internal rotation on the tibia, and orientation of the blade should be sometimes difficult and tricky. So the suggestion is just to cut along the ACL axis in order to be able to follow the axis of the lateral plateau. Now, when doing this, of course, the tibia cut orientation is be very, very accurate, and the surgeon should look very closely to it. Remember that there should be 90 degrees of mechanical axis tibia, positioning valgus no 1 or 2 degrees, no more as an anti-Cortier angle. Never, I say never, put the tibia plateau in a valgus position. This is very mandatory, it's very important in order to avoid any kind of subsidence of the tibia plateau after considering this will be cemented anyhow. Positioning is very important, as much as verification of the height of the resection of the tibia, and that will give you the possibility to be very accurate when cutting the tibia. All the jigs can be very useful in performing this kind of resection, and will help you in positioning both the side blade and the saw blade, both on that longer axis, as we say, of the ACL, but even on the base of the tibia plateau, which gives you the possibility to remove only the required amount of tibia plateau and just the one which is being worn and destroyed by the process of the degenerative changes. And this is very important because then you're going to gain the space which you need to be replaced by the unique component. It's very important when you perform a lateral unit to be very aware of the femoral preparation, positioning the component as lateral as you can. Try once you have a removed limited your ossified, then you have to prepare the base for the acceptance of the component and see how it feels. And the jig, once again, will help you in positioning and fixing and preparing all the components to be placed in the right position. Again, instruments is very useful in doing this, and will you be very helpful in making the preparation of the whole host bone. As you see, there is a possibility to have a wrong positioning of the component. Correct position, as we said before, should be as lateral as possible, both in flexion and in extension, because this will avoid the possibility of impingement of and notching of the component, femoral component into the tibial plateau. If you medialize the component, then you have a chance of having this impingement. So it's very important to have your knee totally free and lateral of the positioning of the component itself. The new design have introduced dedicated instruments that will allow you to have this positioning facilitated by the instrument itself. Now, I'm going to share you the case of this young man, one post-operative day, where the patient, as you can see, actually is a well-known patient because actually it's myself. This was one day after surgery. I'm very happy about the procedure and even more happy with my surgeon for whom we shared the outcome of the patient. But if this was one day post-operative, this was only 3 months post-operative. When you see, I've been able to return easily to all different kind of sports activity, from skiing to golfing and even more to running around. So I think that at the end of this short presentation, I can conclude that lateral unit replacement can lead to excellent outcome. It's very important that selection of the patient is the key. You must be very aware when selecting the patient. Surgery technique is more difficult than when performing a medial unicompartment knee replacement. Bony landmarks are different. You have to remind this and require attention to avoid malpositioning and impingement of the component, especially and particularly in extension of the knee. And newer dedicated lateral base plate overcomes problems of the use of standard contralateral medial base plate. I would like very much to thank all of you for the attention, having given me the opportunity to be present with you. And once again, I send my greetings from Rome. Thanks a lot. See you soon.
Thank you, Franco.
Good morning, everybody.
Your presentation was so good, you set off the fire alarms in the room. Yeah, thank you very much. That was a very erudite presentation. Just a quick question to the people in the room. How many of you have done or have the experience of lateral unis? Right, great. I think, Franco, you brought out some absolutely wonderful points, particularly internally rotating the tibia and getting the femoral component out to the edge. Oh, he's not there. Oh, okay, all right. Okay. Yeah. So, would you like to share your experience on lateral unis?
Yeah, as he rightly said, it's the surgical techniques are a little more difficult than what we do medial unis. And it's typically like a valgus knee. For when we do a total knee, in a varus knee, the techniques and everything that we do are much more simpler. Lateral is always difficult in a valgus knee. Same way, in a lateral uni is difficult. My principle of doing lateral uni is I do a fixed bearing. I don't do a mobile bearing lateral uni. Yeah. The exposure is a bit difficult, but however, a lateral approach and the way he showed to reflect the patella and the patellar tendon on the medial side, and then doing the standard techniques is fine. This internal rotation of the tibial tray is
I think that's the critical part, internally rotating, because typically when you do the medial uni, it's a very different orientation.
Correct.
So it is like people always teach you that uni is not a half a total and lateral is not a medial uni. So if you recognize those subtle differences, so the results of lateral uni are either very good or very bad. And if you, these the little things that you sort of tweak and play around with, and we have the exact same experience. So we had a person who actually flew in from Canada, and his only demands were whether he could ski and stuff, and he had a lateral compartment bilateral. And we did this, and I think he sent us a similar video of him doing these ski slopes and stuff. So it's a great procedure. Weber,
What you rightly said, Ashok, that's because the instruments are such that they are designed as medial, right medial and left lateral. So, you tend to think that what you are doing in lateral uni is exactly opposite of right medial uni, but that's not the case.
It's the exact opposite, I think. And I think you need to keep that in the back of your mind.
I think what I saw in his video is that the sagittal saw that he took, the saw cut, I mean, he put the jig first, and the sagittal saw cut could be adjusted later. So is that a standard thing, or it was only in this jig?
So
he
this
put
is
it
like
afterwards. He put that on the top so that he could angle it the way he wanted it. I thought that the most of the jigs have it pre-decided, which becomes a little tricky.
So I think this is very surgeon specific, Nilan, and those of you who are familiar with this very dear friend of mine, Sergio Romagnoli, is a part of our development team for Persona. He does everything freehand. There is no jigs, there's no nothing. His total cut time is about 6 to 7 minutes, and his total uni time is 10 to 12 minutes. And he is a great proponent of what he calls a B-uni or a bi-uni in our part of the world. He has demonstrated excellent survivorship, almost to the point that 60% of his totals are actually 2 unis and a patellofemoral. And he has this concept of retaining both cruciates. A lot of his patients are high performance athletes and celebrities in his part of the world. People fly in. So you can do this any which way. You can do the sagittal. More of the newer, particularly some stuff like the Persona, actually has a guided sagittal cut interval, and there's actually a pin which prevents you from going down too deep and risking the condylar fracture. Right. If there are no more questions, we'd like to sort of go on. And the next presentation. Oh, Oliver's already here? Good. Yeah.
So thank you so much. This is my last presentation here in this meeting. Thank you so much for your hospitality. It's a great place. The topic that I'm going to talk about is about enhanced recovery protocols in hip and knee arthroplasty. So it looks like it doesn't matter, but as Peter mentioned, no other robotic approach, coupled bearing, could change a little bit more than this, the follow-up and the outcome of the patient. So this is the most important change in the last years about hip and knee arthroplasty in the recovery and outcome of the patients. So let's see. This concept, these protocols start in orthopedics in 2000 with this guy from Denmark. It's a small country in Europe, and they start with this change in the management of the patient post-operative and preoperative. This is Henry Hasted. And at the very beginning, this concept were focused in the procedure and in the outcome, but mainly in the surgical stress and the length of stay. This is the main reason that they start with that. But what about the definition actually? What are the main issues in the definition? You can see here. Wait a minute, because we have sound. We can listen to the sound from here? Or maybe here? Okay, maybe with the microphone, yeah. Yes, you will see the definition.
Oh, hey, Janie, how's it going? Oh, you know, I'm getting better after my surgery. The doctor says I'll still be here for a few days, though. Whee! What was that?
Wait, we forgot to sign.
Why are you guys going so fast?
Beep, beep, we're on the fast track. Why are those guys going so fast? And what's fast track?
Oh, you must mean fast track surgery. We call it ERAS.
ERAS?
Yeah, it stands for Enhanced Recovery After Surgery.
Awesome.
So that's what the definition actually. So going so fast, but so well. I mean, we are focused on the outcomes, and there's a couple of things about the definition. Especially in the US, they are trying to change this definition to the same calendar day surgery when you discharge the patient, but mainly is the outpatient, so the patient can be discharged in the first 23 hours. So the key points for that is the selection of the patient, the anesthetic and the surgical technique, and the rehabilitation. That's important. And we have been mentioned before, but what are the barriers, especially in our public system in Spain that I work in a public hospital. So the main barriers have been described many years ago by Hansted, but the fear and the anxiety of the surgeon and the patient, the complication and the comorbidity, and the side effects. But there is another one, that is the surgeon that said, I always did it that way. That is the main problems that we found. What about the fear and anxiety, how to do it? We can do preoperative patient selection, that's important. I have mentioned before in this Congress, and the complications, we can avoid that with the patient selection and with the optimization. That's very important, the preoperative optimization of the patient. And what about the side effects? How to manage that? With the multimodal pain approach, tranexamic acid, no drain, no urinary bladder, avoid opioids. That's the main issues actually with the management of the patient that have been changed. And what happened with this barrier? I always did in that way. How we can solve it? It's impossible to manage actually. So it's a culture or something that was with the surgeons and the team, and sometimes it's very impossible. What the problems, what the complications, the failures of this approach of the ERAS protocols? So we have many articles. One is we have this nausea and vomiting of dizziness of this patient. This is the complication postoperative, and the patient cannot do a very early ambulation. That's important. Also, we have some kind of problems related to the time of the start of the surgery. These surgeries will start later in the afternoon. It's very difficult to discharge in the first day, and also the pain. That's important. In this patient have a preoperative pain or postoperative pain very high. That's very difficult to achieve this goal of discharge in the same day. These are the main problems in another article for this ambulatory surgical center that is mostly in the US. And the urinary retention is one of the main problems, and the physical therapy. You have problems with starting very early, the physical therapy. This is another issue that you have to achieve to get this goal. And also these problems related to the anesthesia. So the main chain is the management intraoperative and early postoperative by the anesthesiologist of these patients. So there's another issue that is important. Look at this data. I mean, that's very interesting. The patient who know in a previous surgery that they did this ambulatory surgery or these fast track protocols, 70% don't want to go to a new ambulatory procedure. So that's important to think about that. And there is some risk scores that you can check preoperative, and you can think that the patient will be a good candidate or not for this kind of surgeries. So this is the outpatient arthroplasty risk assessment, the OARA, and assess the comorbidity of the patients. And you have these numbers here. So you are between 0 and 79. It could be a good patient or not. Well, we have this medical issue that have been assessed with these OR reports, that the medical and non-medical problems. So these are the threshold that they use to take into account. Take this number, 79 in this score. If you are above that, maybe this is a good candidate, a good patient for this ambulatory surgery or same-day surgery. That's important. And this is the prototype or the best candidate for that. Very young patient between 50 and 60, male, and healthy. And when we mean healthy, we said BMI under 40, as a score 1 or 2, not on chronic steroid, that's important as well, and not chronic disease. These are the main risk factor for a failure of these protocols. And we can modify that. For example, the weight loss is one of the main things that you can do, and the preoperative rehabilitation and the education of the patient for sure. This social support and patient motivation and involvement in this kind of protocols is so important that should be addressed preoperative and take into account for this patient as a candidate for this kind of protocols. So I disagree with the previous speaker yesterday talking about you don't have to give information to the patients. I think it's not my experience. You need to involve the patient with information, preoperative education. That's very, very, very important that the patient feels that this protocols is for him, is not something that comes from outside, is had to involve in this program, and also to meet the patient expectation. That's important to meet these expectations. So what happened in Spain? Just a very quick review. We did this analysis in 2018 with 130 hospitals, and we involved these hospitals that think they are with the protocols, the ERAS protocols, in a correct way. So we involved these 130 hospitals there and look at the numbers. I mean, the main stay in total knee and total hip is around 4 days. Remember that these hospitals are doing ERAS protocols, theoretically. And these are the numbers in this graphic. So what about the length of stay and the adherence to these ERAS protocols items? So in a very dark color, the hospitals that get this criteria to be ERAS, and the length of stay is like that. I mean, length of stay is not the main issue to say that you are doing the ERAS protocol. It's some items that are referral for the patient outcomes and the patient satisfaction in the hospital. So that's important to know that for the ERAS, length of stay is not the main issue. And you can do a very good ERAS protocol and the patient get a good outcome staying 4 days at the hospital. That's a good issue. So what about the new technologies? We include in our public system in Spain this kind of APPs that maybe you know from different companies or different. This is an independent APP that we develop in Spanish, and we measure the walking distance of the patient, the pain. We include the videos for information of the patient pre-op and that stuff, and also collect the scores for the outcomes of that, like for the knee scores and for the hip score. And what are our future directions in our public hospital? Many hospitals are doing that, but we are going to go to at-home hospitalization of the patient. That's very important. I mean, actually, there is a problem with the beds in the public hospitals in Spain, at least, and we have to decrease these numbers of in-hospital patients with these programs that you can take care of the patient at home. So this is our problem in our hospital. We have doctors in the emergency room that cover with new technologies like wearables and everything, and phone calls, and iPad and telemedicine, just to check that the patient is okay. And the patient is at home since the first day, but good care. So my take-home message is that these ERAS protocols improve the patient care, and it's the main change in hip and knee arthroplasty in the last 5-10 years, with the patient education, the patient optimization preoperative, and a multidisciplinary approach, and using the new technologies to get the patient motivated and using in this young patient with the support at home and in this healthy patient. So thank you so much for your attention.
Thank you, Oliver. Great presentation. Any questions, comments from the audience?
Yeah, just out of curiosity, why not female patients? You said the best patient is male patients, and why not female patients? Is there any issues?
This was an article that mentioned that. I mean, the risk factors. To be honest, I don't want to say why. I have my personal opinion, but this is politically incorrect. But that's the numbers. I mean,
Right. If there's no questions, thank you, Oliver. We appreciate your coming and presenting and spending time with us. Much appreciated. We next have another very dear friend, Dr. Al-Balushi from Dubai. He's going to join us online, and he's going to be talking to us about robotics for revision knee replacement.
Good morning, Ashok. And I would like to thank Dr. Bagaria and the organizing committee for the invitation. It's a great pleasure and honor to be with you guys. And my apologies for not being able to be with you guys in India. So my talk is about robotics and revision knee arthroplasty. This is something I started doing recently, so I will share. Are you guys hearing me okay?
Yes, we can. Loud and clear.
Okay, great. This is my disclosure. So we know that the burden of knee revision is going to go up. Yeah, we know the burden of knee revision is going to go up because the primary knee replacement is going up. And we know that 5% of all TKA for osteoarthritis will require revision in 10 years. So if we ask the question, how do partial knee conversion to total do in comparison to a revision and a primary? The answer is worse after 10 years. They have a worse revision and conversion compared to primary and revisions. And the reason for that related to instability, stiffness, and aseptic loosening. And these are all things that we could improve on. And if we look for reasons for revisions, why revisions fail, we see that infection is number one, followed by aseptic loosening, instability, stiffness, because joint line is not restored. So we can improve on aseptic loosening, instability, and restoration of the joint line by improving our knowledge and maybe using better tools. So revision knee arthroplasty is very challenging and demanding. And part of the reason we have bone defects, we have a lot of instrumentation, which create complexity to the OR nurses and the staff around you. And sometimes putting and fixing these bones to osteoporotic bones with defects sometimes is difficult and leads to inaccuracy. And then your bone cuts are done a lot of the time with free hands with the saw because of the reason. And this is a common practice. We know these are the bone defects, and when you have these bone defects, this creates kind of how stable is your jigs when you put them with these bone defects and how accurate they are. Of course, with the surgeons' experience and that, they improve on it and they help to kind of get the things done and the job done. But we've seen like reasons for joint not restored leading to joint stiffness and instability. Zonal fixation, this concept of zonal fixation is very important and we are all aware of it. We need to have at least 2 zonal fixation. A lot of the time in these revisions, the epiphysis is very soft and difficult, like we have defects. So you didn't get fixation in the epiphysis. So you have to go to zone 2 in the metaphysis and zone 3. So you have to get 2 zonal fixation. Now in my practice and all my revisions, I'm using 2 zone fixation, using a cone and a short cemented stem. And this is my standard practice now. So how can robotics help in revision knee arthroplasty? I think it helps by improving accuracy and improves your OR efficiency by using less tray, easier setup, and less manual handling, which I think this is going to contribute to decreasing, hopefully, infection rate. Using a software that you could plan and streamline, hopefully decrease your OR time and complexity of the surgery. So we know that the robotics being introduced, this is the robot that I use. I started with Uni in total and recently starting to use for revision. The software that we are currently using, bear in mind that this is a primary software and the revision software with the augments and the cones will be launched by the end of this year. So I'm going to share with you 2 cases that I've done here. So this is a conversion from Uni to total. This patient had a bilateral partial knee replacement performed 5 years ago. The patient's been in pain since the surgery. She came to me and she's complaining mainly on the left knee. So, you have to do your workup and find out why this Uni failed. So infection workup was negative, and then we did the bone scan. Bone scan showed increased uptake medially. Of course, on examination, it was not overcorrected, undercorrected. The knee was stable, patella was striking well, but she was in pain. So I got a CT scan. Unfortunately, I don't have the image to share with you, but I will share with you this intraoperative finding. So you could see the femur is way external rotated, leading to edge loading, and this edge loading led to pain and early failure. So the way to do the surgery, you put your pens and then you map your femur and map your tibia and get your gaps. And then once you get this information, you come to this screen. So from this screen, you could plan your femur first. And this is how I always start my workflow, start with the femur and the coronal and axial. Because this is a uni, my advice and tip for this case, you have to use a transepicondylar axis because you don't know what they did previously. So whenever I'm mapping these, I use transepicondylar axis. So I go parallel to it, and then I know how much external rotation, and then I will balance my rotation based on the soft tissue information that we have. So here we could see by all what we need to do, we could see the implant thickness on the femur is implant thickness, and on the tibia is the same. So the only thing we need to do just to improve and increase poly size. So we increase the poly size to size 15, and we can see the knee is nicely balanced. So now I know I just need to go and execute my plan. So this is what I did. I performed all my cuts and just left the implants at the end, and you just remove the implants, your femur and tibia. So this way you are below the level, and you know exactly, it's very soft. You could remove it easily with ease. And then once you remove your implants, femur and tibia, you could use the burr just to execute over that area. Make sure that you are flush with on the target level. And this is how the post-op X-ray looks like. So this is another case. This is a revision. So this patient had a bilateral total knee replacement almost 7 years ago, and she's not happy with the left side. She's complaining of a varus thrust and instability. So if we analyze this image, we could see that the left knee is in varus. And rotation-wise, the patella is good. So rotation looks all right, but you could see from the sagittal, there is a patella baja. So probably there is excessive distal femur cut, plus the femur slightly anterior, causing overstuffing of the patellofemoral joint. So you need to know why you are going inside. So this is very important. Your preoperative workup is paramount in revision. That wouldn't change. So infection workup is done, was negative. And we know that this is well-fixed implant with malalignment. And the femur need to be addressed, and also the sizing of the femur. So the workflow is like this. You start your workflow with the preoperative workup, and then exposure, just like a standard exposure, followed by pin placement. So determine your stem size, length that you will be using, and you will go 20 millimeter below the stem. So put your tibia tray usually I put it about 160 millimeter from the joint line. And my femoral pin placement, I put them anterior to posterior, slightly medial, just to avoid my cone and stem preparation. So once that is done, all what you have to do free image collection using infrared technology and building up your model. Second step. So you collect the free collection. Always use transepicondylar axis because we don't know what was the rotation that they used intraoperatively. You can check if the component was mal-rotated or not. So here we dialed, it looked like the component rotation was good. And I use the special marker just to mark the edge of the metal. And then you collect the soft tissue information. So this patient had a malalignment of 16 degrees varus. And we could see the soft tissue imbalance, too tight medially and very lax laterally, leading to a varus thrust. So this is the information, confirm what we knew. So now what we do, we go and remove the implants and then use a special marker where we have the defects. So step 3, this is what we'll do. So you just remove the implant. And then the planning for the revision compared to the primary, because this is, remember, still a primary software that we're using. So minimal base plate poly should be 13 millimeter to accommodate for the difference between revision and primary base plate. So whenever you're planning this on a software, use 13 millimeter poly. And then very important to know, whenever you are using revision, you cannot play with the slope. So slope going to be 0. Your flexion of the femoral component is going to be 3 degrees. And then your varus valgus positioning of both femur and tibia are with 2 degrees only. varus valgus, the same thing for femur and tibia. So we went ahead, we removed the implant. This is very important. When you're removing the implant, just make sure that you take your time, go slow, gentle, minimal bone loss, just like standard revision. So once that is done, now is planning the defect. Visualize the defect, find out the defect. I use a special marker once I remove the implant, so I know where the bone defect is and what the level of the bone we are dealing with. So there are two ways. You could use the special markers, and this is my preference, I use this, or you could use the elephant foot or the mushroom. You put it and see the defect, where it is from the articulated plan that you have. So now you come to this screen. So here you try to balance the knee and using the polyethylene to get you to that purple mark. So on the tibia, we're using here 18 millimeter poly. So I know here I'm gonna use a 10 millimeter augment and 9 millimeter poly. And then on the femur, from the plan here on the coronal plane, you could see laterally, distally, I don't have any bone loss. Posteriorly, the same, medial and lateral and anterior. The only defect is coming from the medial distal. So you go ahead and you see it and you visualize it. You could see basically the defect is mainly coming medial, and you could size that defect by the technique that we showed. So here I needed the 10 millimeter augment distally medially. And the tibia preparation is straightforward. Once that is done, then I use my Anthem component and I check the balance, and I know the balance is good. At this point, I remove the pins and then I prepare for cones and stem and final implantation. And this is the X-ray of this patient. So we could see, we could address this patient's alignment, patella height, and rotation of the components. The beauty of this technique, I mean, it really decreases your instrumentation. So this is exactly what we use for this case. You need your stem preparation, cone preparation, and then your trials. That's all what you need. So decrease, for me, the system that I'm using from 15 trays down to 7 trays. And it really helps in theater to kind of do the surgery in a timely fashion. And we don't know the data about the survival and infection rate and how they're doing. But I mean, this is something that we started recently. So we are collecting the data and we will share those in the future. So in conclusion, I believe robotic in revision knee arthroplasty is still in infancy, but it really helps with joint line and soft tissue balance. And you have a precise tool that allow you to execute and minimizing your instrumentation and cost of instrumentation. And we don't know about infection and survival long term. But I think if you have better tool to execute, must lead to better results. Thank you very much for your attention.
Thank you, Ali. As always, a very elegant presentation. It'd be interesting for us to hear from you, hopefully, at our next meeting, what your experiences have been and how the patient's been reacting to this intervention. But from whatever you presented, it seems to be a very logical way. So from the panel, yes, Peter.
So thank you very much for a great presentation. My question for you is, what parameters can you change with your alignment? You said a couple of degrees varus valgus and a couple of degrees on slope. Is the main change in alignment your rotation, your femur, where you can play with? Just put it more external or internal rotation if your flexion gap is not matched? Is this what you use it for?
Yeah, well, I think the alignment philosophy is going to be, you're determined by the stem up and down. So, I mean, you cannot do much. It's just like 2 degrees varus of valgus, that's all. But I think is getting the joint line right. That's the key. And then getting your soft tissue balance right with the minimal kind of PS. If you can put the PS, and you can check stability. So when you leave in theater, you know that basically you restore the joint line and stability of the knee. Alignment is determined by the step up or down. But the flow and efficiency, I think that's another advantage.
And just remind me, how do you get your joint line perfect?
Yeah, so the joint line, basically, you have to do your assessment preoperatively, why this implant failed and where the defect is. So you could use the transepicondylar axis, transepicondylar points, medially and laterally, if they are there. and then you can drop a line from that based on the anatomic studies. If it's going to be from medial, you're going to go 3, and if it's lateral, it's going to be 25. So build up from the femur, the joint line, distally, and then posteriorly, it's determined by how much defect you have, and then the flexion gap based on the soft tissue information. So you can bring down the femur to close the flexion gap. So the nice thing about it here, you are using the soft tissue information with the bony landmark that you have to build up the joint line and the stability of the knee. With the PS constraint, if you could do with the PS, if you can. If not, then you can do constraint liner. So I think the key for the software, it helps you because you have bony and soft tissue, and you could use the precise tool to mill the bone away.
Ali, just taking off on that earlier question, how important is it, and what are your sort of range, if you will? Because we know that with revision, almost always you're going to be somewhat altering your joint line. What is your threshold? Is it 2 millimeters? Is it 5 millimeters? There are some people, Kelly Vance, for instance, who actually says joint line restoration doesn't matter. And there's, the literature is all over the place. Would like to understand from you, what's your sort of headspace? Where are you comfortable?
You see, that's an excellent question. So the question, joint space doesn't matter, joint line doesn't matter. I disagree with that, because your patella is sitting at the front. If you want the knee to flex 90 degree and you accept a 90 degree as a flexion, then joint line doesn't matter. You just want a knee that basically flex to 90 and extend. But you know, where you and I are practicing, patients come in with primary knee replacement that flex fully. And to get the joint line right, that really helps your patella tracking. So I really use my bony landmark, my joint line, my medial lateral epicondyle, and then drop in the joint line, building from the femur distally. Posteriorly, where is the joint line? It's based on the flexion gap, how much flexion gap you have, and you want to close the femur down, and determined by the anterior cortex. So you could nicely play with it with the software before executing. So that's the beauty of this. You are working on a simulation to get the joint line best position that it fits your gap balance that you have.
Yeah, I would totally agree. I think for me also, restoration of the joint line, and to your point, restoring the patellar alignment and the patellar height in relation to the trochlear notch and the groove is probably one of the most key factors in ensuring that you have a good articulation, good movements, functional range, and a happy patient. So, yes, Weber.
So, brilliant talk, Aliyah, as always. Not a question, but a comment. I think what you demonstrated was a very good use of the special points. And I think they are a brilliant trick when you're doing revisions and even in primaries. So, those different colored points that you saw are sort of a second check that you can make for the transepicondylar axis. So, that would be a perfect liaison between the man and machine. So, those special points are your natural instinctive point that you see as a conventional surgeon, and I think in revision they are very helpful, and you demonstrated it very well. Thank you.
Right, on that note, I'd like to thank...
absolutely, yeah, thanks a lot.
Thanks, Ali, and thanks for being, and next time we would really love the opportunity to having you with us in the room, and enjoying all the banter and the hospitality and exchange of knowledge. Thank you for being with us, Ali. Really appreciate it.
Thanks a lot, appreciate it.
Right, a slight change in the program. Dr. Tanna's talk is going to be a little bit later. So I'd like to bring on Dr. Thorsten Gerke's presentation. He's not joining us, so we have his presentation. So can we upload it and have it run? It's pre-recorded, yeah.
Everybody, dear colleagues, dear friends, especially my friend Ashok Rajgopal, who invited me to give you a talk this morning about the diagnosis and treatment of PGI. Already 51 years ago, Surgeon Charlie stated that the greatest challenge of total hip arthroplasty is to eliminate the PGI completely. The PGI, the periprosthetic joint infection, is an ever-present danger. The sword of Damocles is swinging always above our heads, because whenever we perform any kind of arthroplasty, we are in danger that this get infected. Regarding the diagnosis, there are multiple definitions. Almost every society has his own definition. That means diagnosis of PGI is not really easy, it's difficult. What about our current pathogen identification methods? It's a very old technology, it's imperfect, it's technique and lab dependent, it needs time and many more. It was inaugurated by Koch in the 19th century. The main advantage of the cultures is that we are able to test the susceptibility of bacteria for different antibiotics. Unfortunately, worldwide, we are faced with the phenomenon that we do have more and more culture negative results. And this is a big problem because we do not know which weapons, which antibiotics we have to use against our bugs. And another problem, what makes it really difficult, is that sometimes even the blood parameters like CRP are normal. In our cases, we did a study about 1,000 cases, and in 15% of definitely infected PGIs, the CRP value was normal. Here is no doubt. This is a really proven periprosthetic joint infection because you can see the implant. Why it is so difficult to identify the bacteria? Because the bacteria are able to develop some tricks. Some of them are able to hide in cells and survive in cells, like you can see here, an intracellular Staph aureus in the periprosthetic tissue, who hides himself in an osteoblast. Another trick is that the bacteria hide themselves in bone canaliculi, as you can see here. So our algorithm, how we diagnose the periprosthetic joint infection, is based on the ICM algorithm that we developed in 2018. I will go through this algorithm together with you with this patient, Paul, 60 years. In the X-ray, you could see some changings over the years from 2013 to 2020. The greater trochanter almost disappeared, and he came to us with massive pain in the right hip and with this X-ray. What about pain? In the consensus meeting 2018, we asked the question, what is the most sensitive clinical sign of infection? And the recommendation and the answer based on the literature is that pain is the most sensitive, but unfortunately least specific clinical finding in PGI. So whenever we have a patient with an unexplained pain in a joint which was replaced, we perform an aspiration because the ICM algorithm is based on the findings of the synovial fluid. One question could be, because Paul had prostheses on both sides, should we aspirate both sides? We did a study and published it recently where we looked after 3 different groups, which implants on the same side, contralateral side, or upper and lower limb. The result was the so-called metachronous PGIs are significantly higher in patients or infections where we have a polymicrobial primary PGI, where Enterobacter is involved and which is based on diabetes mellitus. Second question is, where should we perform the aspiration? How do you perform the aspiration? We do it under fluoroscopy. Some doctors worldwide do it CT guided or ultrasound guided. That in our hospital still. Fluoroscopy guided, here you see a sample, how we perform our aspiration. Immediately after we get some fluid, we perform the leukocyte esterase test, and the rest of the fluid we send to the lab to do some investigations. And what is the result of the investigations? In Paul's case, the left hip was normal. There was no signs of or no suspicion of infection. On the right side, it was very suspicious because cell count was very high, more than 17,000. The cutoff for cell count is very different in different studies, but our cutoff is about 3,000. Probably the cutoff is different between knee and hip arthroplasty. In our patient group, our cutoff in total knee arthroplasty was about 1,600, in total hip arthroplasty, 3,000. And another problem with the cell count is, and we studied it and published it, that the cell count is elevated in most of the aseptic revisions. Unfortunately, or let's say interestingly, PMN% not. What's about the neutrophil percentage? Paul had a PMN% of about 86%. The cutoff is 70. This is really a take-home message. PMN% is the most sensitive parameter in the synovial fluid. We did studies about it in acute PGIs where PMN was the best, and in chronic where PMN% was also the most sensitive one, with a sensitivity of almost 93%. So it's also the best in the chronic. What's about leukocyte esterase test? Leukocyte esterase test, in my opinion, is a genius one because it's very, very cheap. It's available everywhere, and it's very quick and easy. Leukocyte esterase has an extremely high sensitivity, and you can even rule out the infection with a normal leukocyte esterase test. What's about alpha-defensine? We did some studies about it. Alpha-defensine is not available everywhere, but in Paul's case, it was also very high. So if you put it all together, Paul came to the summary of about 7 points. That means he is infected. He had more than 6 points. But unfortunately, our culture was negative. And if we have a negative culture, we repeat, that's another case, we repeat the aspiration 3 weeks later, as you can see here, and sometimes you find a germ in the second aspiration, and then you can perform the one stage. If you cannot or are not able to detect the germ, we recommend an open biopsy. In open biopsies, as we published before, the open biopsy procedure led to the identification of the causative germ in about 40% of the cases. So we did an open biopsy in Paul's case, and we found Staph vanneri and Cutibacterium acnes, and that means, according to the ICM algorithm, Paul reached about 12 points. We knew the germ, and we performed a one-stage exchange. That leads us to the molecular testing. Molecular testing is very helpful in culture negative PGIs. Here are the most common molecular techniques: broad range PCR, multiplex targeted PCR, next generation sequencing, and so on. Broad range has advantages and disadvantages. It's very, very helpful because it can detect all types of bacterial species. It has some disadvantages because it detects only one bacterial that is the most abundantly present. Multiplex targeted PCI is at the moment very, very common, very fashionable. So it has a lot of advantages. You can really find about 39 different bugs, including some yeasts, but unfortunately, it is not able to detect coagulase negative staphylococci and C. acnes, which are the most causative germs. It's indicated especially in late acute and hematogenous PGIs. Probably the best one is the next generation sequencing with a lot of advantages. It can detect even polymicrobial infections. It can detect resistant genes and can detect all types of bacteria. It's really great. You can detect more than 30,000, and in the meantime, it's quite cheap. So in US, they use it very, very often, and it's based on the ICM algorithm, and then they give you the germs, mostly a row of germs, and then even the susceptibility. Literature says it's a very, very helpful tool, especially in polymicrobial infections. And here are some multi-center study which shows you that in about 66% and 2/3 of the culture negative patients, next-gen sequencing is able to detect the bacteria. It's indicated in late chronic, late acute, and early post-surgical infections. Let's come to the therapy. First of all, if you like to treat a periprosthetic joint infection, you have to do it via a multidisciplinary approach where all the different specialties and specialists have to work together. This is a prerequisite for any kind of septic revision, not only for the 1 stage, also for the 2 stage. The 2 stage, as we all know, is still worldwide the golden standard, but I would like to put a big question mark behind it. Why not the 1 stage? What makes you nervous about the 1 stage? Lower infection control rate, limited ability to deliver high-dose antibiotic bone cement, difficulty of re-revision, and so on and so on. Our algorithm in the endoclinic is quite simple. If we know the germ, if the biofilm is mature, if local antibiotics are possible and a radical debridement is possible, we go for the 1 stage, otherwise we perform the 2 stage. That means the key of the success in the 1 stage is the knowledge of the germs which are responsible for the PGI. We have to know the susceptibility of the germs because we have to know which antibiotics we have to use. I'd like to show you shortly how we are performing it. First of all, we start with a surgery, debridement, and as you can see here, open the wound, debridement, and removal of the implant, cemented or uncemented, doesn't matter. In our opinion, every foreign material has to be removed, even if it is well fixed. You have to clean the bone. You have to do a thoroughly debridement with different tools until you have the impression that the bone is really clear. You need tools, you need some kind of irrigation. And then after you have finished your debridement, very, very radical and very, very thoroughly, you can proceed with the systemic antibiotic therapy, which we do after, we give after keeping out the last biopsy, which is followed by mixing the cement and an irrigation with an antiseptic solution. As you can see here, we put in the antiseptic solution, which needs about 15 to 20 minutes to act. And during that time, we change everything. We prepare antibiotic-loaded bone cement tailored to the susceptibility of the germ. And the next step is the exchange of the drapes, gloves, instruments, any used tools. Here, the drapes have to be renewed. Of course, we change the gloves, we change the land grips, we change everything before we start the re-implantation of the new prosthesis. Reimplantation of the cup is usually, in our opinion, should be done with a dual mobility cup because due to the radical debridement, we need some protection against dislocation and instability. Here we use usually trabecular metal cups, in which we are cementing a dual mobility cup just as a precaution against instability and dislocation. This is very helpful. And the next step is a re-cementation of a stem with antibiotic-loaded bone cement, again, which is tailored to the susceptibility to the specific germ. Modern cementing technique, of course, usage of jet lavage, pressurization should be performed, and then you can cement the stem, as you can see here. We still believe in the concept of antibiotic-loaded bone cement in the one-stage procedure. Not everybody does it, but this here you can see the surgery is done. You can close everything. It looks quite safe. Post-operative treatment, usually the patient is staying one night on the intermediate care. Early mobilization, usually with full weight bearing. IV antibiotic therapy for 14 days, followed by oral antibiotics, but mainly 6 weeks. And the patient usually is discharged after 2 weeks. Results of the one-stage exchange. You can find a lot of studies about the one-stage exchange, as you can see here. Interestingly, they all show better results than the two-stage. Here, for example, very interesting, the Pavisi group, they published a success rate of just 65% at the two-stage because they defined as a success reimplantation of a new implant. And here we define the surgical success as this, you're doing the ICM meeting. And if you do not perform a reimplantation, you are not successful. Success, again, is defined as reimplantation. Worldwide, there are 2 prospective randomized studies in the meantime. First of all, is the INFORM study, which was published about 16 months ago by a British and Scandinavian group, where they found that the single stage had a better outcome at 3 months, fewer intraoperative complications, and was extremely cost effective. And the next one is the most recent one in US. It was guided and led by Tom Faring from the Ortho Carolina group. And the preliminary results after 1 year in almost 300 patients showed that the rate of efficiency for the one stage is 98% and for the two stage 92%. Last week I was sitting together with Tom Faring and we discussed his results, and here you can see after adjusting for comorbidities, the one stage treatment had a nearly 4 times the odds of success than the two stages. After adjusting for organism resistance, also nearly 4 times the odds of success. And after adjusting for draining sinus, one stage treatment had nearly 3.5 times the odds of success. That means the one stage is coming up more and more, and probably in the future, as this paper from Sweden stated, the single stage procedure could therefore be the new gold standard for treatment of non-complicated PGI in the hip. My warmest regards to all of you in India, and apologize that I cannot be there in person or live. Best regards from Hamburg. Hopefully see you soon. Bye-bye.
Right. Unfortunately, there's no questions because this was a pre-recorded talk. Any comments from any of the people in the hall?
what do we have available here in India, so that we can, do all this test, to all these people who are working?
Yeah, so I'll tell you what we have. We have the BioFire, we have the NSG, and obviously we have the Alpha Defensin. So those are the three that we at our center have. Wherever maybe you can comment on that.
So we have almost everything that they mentioned. Leukocyte esterase we routinely do for all our urine pre-op checks. Their strips are available. BioFire we routinely use. We are one of the first centers here to start using it in the country. Next gen sequences is available. Pune has got in fact, a very good lab where you can send it for extreme detections of viral genome. So in fact, post-COVID, it has been a tremendous progress in detection of infection. Our ability to sequence different subtypes is so high. And we recently had a case in which we cultured for so long and ultimately sent it across. Despite all the TB cultures coming negative, they could sequence an atypical mycobacteria. So the ability to gene sequence today in last 3 years has grown leaps and bounds. So NIV, the National Institute of Virology, does beautiful work for they can even sequence viruses now as an infection. It's something which is now coming up. Some causes of painful knees. We don't know if there is some chronic viral infections. They're talking about it now. But yes, I think in next 5 years, we'll see more and more information on that. Okay.
So one very clear message from his talks are that once you have the organism that is recognized, you can go ahead with a single stage. So Dr. Rajgopal, would you do that, or Nilen for that matter, would you do that?
I think there is compelling evidence in literature. Have I done it so far? I have not. But I think when you talk to people like Wolfgang and you read literature, and particularly from various supporters of the one stage, what seems to be emerging is in the right quadrant where you can isolate your bugs and get a sensitivity. The results of one stage are definitely better, and I am open to that. Like I said, I have no personal experience, but I think it's certainly a path worth pursuing.
Yeah.
Maybe I just could add, I mean, this is, I think probably the most important part of it is really then when you decide to go for one stage is the surgical procedure, because this is a very radical therapy. I mean, it's like the debridement that you're performing for one stage is much more radical as for two stages. And very frequently when I do a repeat second revision or so and converting that into a one stage, I often find debris that has been left in place or cement or maybe a screw or something like that. So it basically, or suspicious bone or something like that. So the key point, I think, is that you have to be so radical that you remove really all debris and all foreign material. And even if the bone looks infected, you have to remove that as well. You have to cut it out. Otherwise, the infection will come back.
So we are moving now in our institution more and more to the one-stage revision. I think for the early infection for hips, it's more effective than just a line head exchange. If the hip is not ingrown, it's within the first 6 weeks. It's absolutely worth to change the whole components because it's one hit and you get it out. The debris is easy. The bone hasn't been that damaged yet, but the effects for the patients are much better. As for the knees, we are moving now more and more to that technique. But again, if we have a culture, if we have a positive culture, and if we know what kind of germ we have to deal with, so we know we have a treatment afterwards.
Yes, may I just say, yeah. I mean, he showed a hip here that he did a one stage on. I had the privilege of visiting Hamburg and I had met Wolfgang there also. So when they are doing a one stage on the knee, they just take off the collateral ligaments, really debride it, and then they put a hinge, I have some reservations about putting a hinge in, say, a 60-year-old or a 65-year-old. So I would like to ask Wolfgang that if you do not take off the collaterals in a knee whilst doing a radical oncological type debridement and follow the rest of the procedure and not put in a hinge and do a standard constrained knee, have you done that? And do you think it will work? And would you have the same result?
Yeah, I think it's going to work. I'm doing it as a matter of fact. I'm doing quite a few one stages. So I think that the key here really is that you probably need to thin out the collaterals to some extent, but to tell you the truth, as long as the posterior capsule is intact, you have to debride that as well and also on. Then you probably can get away with a CCK type of implant. I know that it looks very radical when you cut off the collaterals and then put a hinge. And that's my biggest concern there as well, to tell you the truth. They looked at their 10-year results or 10-plus-year results, and they said that they didn't see a higher failure rate, but we all know that as you increase the level of constraint, you're going to see that. So I've reverted, and I have actually I'm doing a very aggressive debridement. I thin out my collaterals. I'm really cleansing them and all the gutters, but I'm then dropping a CCK, even with a hybrid type of fixation nowadays. There's guys in the UK and Stanmore that are doing cementless revisions in those one stages. I wouldn't go as far as to that and say, we're going to do a cementless one-stage revision, but it would be ideal to have that in the future, because we all know that infections can be caught by young patients as well. And that would actually then lead to some tremendous impact on the future implants that we're going to put back into those patients.
Also, I guess the availability of sleeves and cones has added that little insight into the challenges of ensuring a stable fixation in the metaphysis. Right, on that note, we are going to take a very short break, just a 15-minute break. So can I request everybody to be back here 11:05? We'll have the panel discussion and hopefully the other two speakers. 11:05 will kick off again.
Right, give this to you girls, or
I like to talk a lot about the biggest reservation that I'm having against registries is that they don't specify the type of implants that surgeons don't like to revise. You know what I mean?
Yeah.
It's like if you have a hinge and it is a failure because it doesn't work, they don't revise the hinge, you know what I mean?
It's not coming in first.
No.
I've given him 10, 15. Ahead of time. रुक जा, अभी मैं लगाना 2 मिनट, अभी से नहीं लिया ना. Yeah. And then you can be somewhere at 3 o'clock. You can leave from Trident and come here at 3:30. Go out 3:15. You can leave. The bus is at 4 o'clock.
Where is the bus leaving from here?
From the beach, midway between your hotel and this place. No, not from the hotel, because there's a fixed track. It's a double-decker bus. So they've got a track which is fixed. They will not pick up from the hotel. Okay. Government bus. So
3:30. You'll be here.
Yes, 3:30 you'll be at. So 3:15 you can leave for the 45 at the beach.
So we pick up.
Yeah. What is arranging you? We pick up
3 hours.
And the rooms are not released, so you've got your rooms with you.
Well, I've got my mine have you my room.
You can use that.
No, I won't.
हा बोला. हा मला सांगितलं. यांनी आता जस्ट सांगितलं की की हे आहे आपला पार्स आहे. हा मी ते लावू शकतो ना. ते लावू शकतो लागू. He'll come. He said he'd gone for a trek but got late, so it's coming at 12.
But what time is it coming?
12, he said.
Wait for him.
No, he's here.
No, in Canada. I mean,
That's why he's come to an Indian time.
Oh. Yes. Maybe we'll be more later.
Yeah. What about you guys?
Yeah.
It's okay.
It's okay.
I'll just do a quick industrial one. Most people.
Yeah.
or you can announce on this.
Hello, the session is about to start. Hi, the session is about to start. I request all the doctors to join us inside.
So welcome back, everyone. And it is my pleasure to invite the panelists for this session. Dr. Rajgopal is already here, Dr. Nilen Shah, Dr. Mohan Desai, Dr. Clauser, and Dr. Satish Modi. Please join us on stage. Dr. Mohan Desai, is he here? Yeah, please call Dr. Mohan Desai. So thank you everyone for being here. This session is primarily to kind of have some kind of balanced view. We have had a lot of controversies, but it's an attempt for us to move from controversies to consensus. We all know that we are changing and that sometimes change is good and sometimes change is not so good. But the only thing constant is that the change is constant. And as this quote says, every generation imagines itself more intelligent than the one that went before it and wiser than the one that comes after it. So it's indeed the right time to talk about it post the Wisdom Studio from the wise man. So we all know that knee replacement are not as good as we like them to be and that 20% patients are dissatisfied. I know Dr. Nilen Shah has a different view, so I've put it specifically to provoke him.
So Vaibhav, I think if 20% of our knee replacements were dissatisfied, I think at least in India, you would not be able to practice. Because it is mainly word of mouth. You don't have a captive patient population. And generally, I think there was a very interesting paper published in the British JBJS, which was called as the Friends and Family Test, or the Net Promoter Score, as to how many patients that you have operated are actually bringing you more patients. So the industry standard of a Net Promoter Score is even 0.5, that at least 50% of patients are bringing you more patients. It's considered to be good, like Apple or Samsung would say that. In COVID, when I was not doing anything, I looked at my Net Promoter Score. I asked my staff to, speak to all the patients that were operated earlier. And the score is something like 0.93, that the 93% of the patients that I have operated are actually bringing in further patients to me. So I have serious doubts about the applicability of this 20% TKR patient dissatisfied, at least in our Indian setting. And a lot of the technology which is being built in or which is being promoted to decrease this supposed rate becomes a little iffy, because I have doubts with I mean, I'm not doubting what he has said, but I don't think it is applicable, at least in the patients and the practice that I have.
Yeah, so there are truth and there are lies and there are statistics. Okay, so a show of hand, how many people feel that the percentage of their dissatisfied patient is less than 5%? So I think all the top surgeons here, that it is like less than 5%. Oh, yeah, you are, oh, yeah, here's a question, yeah. Yeah, so please feel free to join in the conversation. This is a conversation rather than a very set thing.
Yeah, I must say, I work in a public hospital, so maybe my patient is 0% dissatisfied, but all of them come to me again and the families and everything because it's free. So you need to take into account that. I mean, we are different environment. We are talking about private practice because you are cheaper or you are good. What's the main issue with that? So maybe the paper is talking about outcomes for the patient, not the way to come back to you. So if you measure the outcome, it depends on the score you use. If you use a very accurate outcome measure, maybe your results are not so good. So that's the main issue. What are we talking about with dissatisfied?
Yeah, dissatisfaction is a very, very subjective term. I've had patients who are satisfied with their needs but have had a loss of hair fall after the surgery, so they're dissatisfied because they've lost hair. It is a very, very crazy sort of thing. It's also the mental attitude. A patient who is depressed, who lives alone, has Parkinson's, doesn't have family support, with a good outcome has a dissatisfied patient. But I think I agree to a large extent what Nilen said. The majority of patients, by and large, if you ask them, would you undergo replacement surgery again? You ask them that question at 6 to 8 months, 30% of them would say yes, 70 would say no. And you ask the same question at 2 years, the odds would be reversed. 85, 90% of them would say yes.
So can I just make a remark? If you go back to your first slide, almost 20% of patients of TKR are dissatisfied. Are you sure it's dissatisfied or not fully satisfied? Because there's a difference.
Yeah, we Indians are not very good at semantics. So for us, dissatisfaction and unsatisfied probably means similar. We can always play on the words, but that means that there is scope of improvement, and that's my slide. Whether they are dissatisfied or unsatisfied, there is a scope of improvement.
Not fully satisfied. There's a difference between that also. Yeah.
So that's what. So fully satisfied and dissatisfied.
I have an
There's a play of words.
It's not a play of words. There is a difference.
I have an example with the hip. I used to treat very young patients with hip replacement and hip arthroscopy. And I used the same score for both, the IHO 33. So if you use the Harry Hip score for the very active young patients with the hip problems, all the patients are great, are more than happy. But when you ask them, they are not so happy because the expectations are different. So you need to use the correct score for the correct patients. That's the main issue. So, and these patients are dissatisfied, but in the Harry Hip score is perfect. But with the IHO 33, you can measure this difference, you know.
So in Germany, we are actually looking now more and more into PROMs, and I think that Peter will tell you that the registries are looking into that as well, because the Swedish registry is actually catching the PROMs, and the PROMs are really probably the best way of catching patients' satisfaction or dissatisfaction. And I would strongly encourage you to do that as well in India.
And also, going back to something that I say very often in these meetings, Gil Scuderi's work from 20, that 26%, 25% has gone down to 7%. It's also what questions you ask, how you ask that question. You ask a leading question, usually you get the wrong answer.
So I think you answered all the three questions. How are you good? I think majority of people said yes, they are good. Are we getting better? You just said yes, we are getting better. And you said, how do we know? So we score. So I think these are the three fundamental questions that we needed to answer. And thanks, panel, for answering that. But coming to the point that we are restless humans, as you said, for you, patient not fully satisfied would probably not equate dissatisfaction. But for most people, not fully satisfied means a room for improvement because we are restless people. So what problem are we trying to solve? Why are we having these meetings? What is the single most problem that you think where we can improvise? Professor Modi, you have seen the most among all of us. What are the problems that we are trying to satisfy or change when you're looking at arthroplasty?
Most of us operate on patients who have waited for this surgery for as long as they could, maybe 10 years, 15 years. Last week I did a surgery, a bilateral knee, whom I had seen 15 years ago and advised, but he wouldn't do it. So our patients are very critical. They have apprehension of any surgical procedure, whether it is total knee or a hip or even hernia or hydrocele. So they will go to 15 various sources to find out whether this surgery is necessary and whether it can give rise to good results and which is the best place to do it. I have some patients who come to HN hospital because they think HN hospital gives the best nursing care. So then they will choose a surgeon, either Nilan or Vaibhav, to get the operation done here, while other hospitals may be giving the same treatment modalities, perhaps a little bit of less satisfaction in nursing or atmosphere. So it's very difficult to find out. In the West, a patient who has no support of any kind at home, no social support, has minimal complaints according to our standards, would undergo surgery, and if he should be happy, then he should be happier than our patients. But it is not so because there are many other factors involved. So as Dr. Ranawat used to say, the unhappiness or the bad results is either here or there. Now, how do you find out whether it is there or not? So that's difficult.
No, very valid point, sir. And I think you made two very important points. Patient education, I think that's where we can improvise certainly on when to do it and how to do it. And second point, I think what he made was sometimes patients don't know how good you are, but they look at how good you care. And I think that's more important, that if they have to believe that you will care for them, then they'll also automatically assume that you're good for them. Okay. Yeah,
just a little point that I wanted to mention in respect to what you just said. We actually published a study, I think it must have been this year or last year, looking at what happens if you actually have nurses call your patients after surgery and how that would impact their prompts, their patient-reported scores. So we could find that with hip and knee arthroplasty, if you had nurses calling them your patients every 3 or 4 months or something like that, asking them how they were doing, and telling them that they were just looking after them, that you could so much significantly improve their results and their well-being, their feeling of well-being, that the satisfaction rate greatly improved. So I think that if you are smart, you are going to actually get a couple of nurses that are going to call your patients, and then you're going to significantly improve the outcome, the clinical outcome and the personal feeling.
Agreed. Yep.
Just one other point, Vaibhav. I think the interesting part about both hips and knee replacement, more so knees than hips, is patient expectations, matching the patient expectations. And the kind of cohort of patients that we see here, a patient like Dr. Modi said, has not had surgery for 12, 14 years, and obviously has a pretty significant deformity. Compare him to another patient who's got 10, 15 degrees of varus for 8 months, 12 months, 14 months. The outcomes in the two are going to be very different. A stiff ankylosed knee is never going to get 130 degrees of knee flexion. But when you sit in a social environment and compare your outcomes with somebody else's aren't, that's where the discrepancy starts. So I think patient education, telling them what this surgery is going to be able to achieve for them, goes a long way to achieve. You can have two patients with completely different outcomes, and both of them are satisfied.
I agree, sir. Points well taken. Yep, please, Mike.
I totally agree. So patient satisfaction is patient information, is talking about expectations, and is showing them you care. If you look at your reviews, whenever they have the feeling you don't care, you get a bad rating. If they feel you care, you get a good rating. And it's not about scores. It's about the amount of care you show them.
Yeah, so more objectively, these are the two things we are chasing, or we...
Vaibhav, we should be less in theaters and more in clinics, because you have to listen to them.
So no confidence in arthroplasty can be complete without this slide and this slide. So what has changed? Professor Mohan Desai, do you now look at all the knees differently since last 5 years? Or the way you
Yes,
look at
because
X-ray,
now
has it
we
changed?
have this sort of a classification. We know that every knee is not the same, and perhaps we are thinking that we put the same knee in the same alignment. So it has changed the way one would align the knee, perhaps, and sort of personalized alignment would be a thing to go. Though the long-term results of various personalized alignments are not there other than perhaps the kinematic alignment, but that is the way to go.
Yes, I think the alignment philosophy and the way of looking X-rays certainly has changed. Whether we have implemented in our practice or not is a question, but I believe.
If you just go back to the previous slide, now I have looked at this classification and it still looks, very, very complicated to me. So when I am doing a non-technologically assisted knee replacement, the thing that I want to know is whether the knee is in varus or valgus, and whether the femur is in varus or valgus, and whether the tibia is in varus or valgus. So if I know those three things, then depending upon even the mechanical instruments that I use, it will guide me as to what my cuts are going to be like. And at least that is what I mentally do.
So I think very valid point. No matter how much technology progresses, I think it's ultimately the human decision making. All this objectivity that this particular paper has brought is probably already there in the minds of people who have been doing it for years. It's just that it's not articulated, or it's just not put in the grids. We humans are now getting increasingly boxed by the grids, but I think what is there is much more beyond the grids as well. So.
Whenever I see that slide, Weber, something inside, the animal inside me wakes up, I, for the love of me, I'm not a maths geek, which is why I became a doctor. That graph looks insane to me. Absolutely insane. And I've gone to several meetings and they say, CPAC 5 changed to CPAC 3. Big deal. So what happened to the patient? He's still the same. You can do all these grids and red dots and blue dots and purple dots, but if that does not translate into better outcomes, and I keep going back to one of my most favorite papers that I refer to, Joe Matar from July 2020 JOA. He did a meta-analysis of close to 67,000 patient population, did something like about almost 1,200 meta-analysis, and the outcomes that he came out with is, regardless of what you do, whatever form of fixation, whatever form of alignment philosophies, the outcomes remain more or less the same. So he compared this with that, patella, no patella, kinematic, restricted, whatever. So I think the basic philosophy is to sit down with your patient, understand his problems, understand his anatomy, explain to him, first to yourself in your mind, where are you taking this patient from here to there, and do a well-balanced knee, whatever well-balanced, and there are 20 people in the room, well-balanced knees will mean different to everyone. So if you can deliver that, match or temper his expectations, I think you're going to be a good surgeon with a happy, satisfied patient.
I think, sir, you said one should be stubborn about their goals, they can be flexible about their methods. And the goal is what you define for yourself. So I think very well said. Professor Kloser,
No, I was just referring to that graph that you were showing. The problem that I'm having with these graphs and also the alignment strategies is that they're all basically going and looking at static situations of the knee. So if we consider patients that they are constantly walking and having a dynamic balance of their knees, we don't consider in these graphs any hip abductor weakness, and we don't consider any hindfoot valgus, which has a significant impact on the way that the knee is functioning. So I think that if you're talking about alignment, we have to find strategies where we actually look at these points as well, and I think that artificial intelligence in that respect, looking at how patients walk, how they balance their knees, and how their hips work, and how they put on their feet is going to be one of the future improvements that we might look at, and then we are going to have the point there.
Point well taken. So again, yeah, we talked about how can we be better by evolving controversies to consensus, avoiding errors in execution, and of course, validating and real-time corrections. So let me address the elephant in the room. Has technology made a difference? So Mohan Desai, you've recently acquired a robot. Oh, Dr. Modi, yes.
Sorry. We have to go back 30 years or more, and we should ask this question to Meryl Ritter, Ranawat, Insol. Why were their results good without so much of technology and robot and even navigation? Were they good? Because they were painstaking in delivering with a limited either mechanical axis or a functional mechanical or anatomic axis. If I see my some results 30 years and 25 years, very simple IB2, not much knowledge about many things that we have today. They are happy, they are mobile, independent, and walking. So are we doing an overkill by getting more and more in technology or not? I think we have all got to sit down and discuss.
Very interesting point. And that brings me to Dr. Rajgopal. Sir, you have worked with John Insall. You think John Insall would have bought a robot? Hypothetically. You know his personality, innovation.
I would say yes, because John was one of those individuals who was very, very open to innovation. And I'll tell you a little anecdotal story. I was with him twice in 99 and 2000. And he made a very interesting comment about IB2. And these are words straight from John Insall himself. That is the worst knee I ever put out in the market. And if you are absolutely honest, God bless his soul, that is the universal truth about the Zimmer portfolio of knees. The worst knee that came out from the Zimmer's table was the IB2. It had an extremely high incidence of loosening. The tibia was going off until everybody recognized that and started putting stems into it and became a great. It was a unipolar. They didn't have right and left. The locking mechanism was decent. So and he was the first one to actually acknowledge that. So when they moved from the IB to the next gen, he was both unhappy and happy. And so the answer to your question is yes, he was a progressive man with progressive thinking. He was an innovator. He was a researcher. And I would imagine if he was around right now, he'd be a little more comfortable knowing that using his implants or his thought-provoking implants with technology which are giving better results would be the way to go forward.
So yeah, so some early results which are showing some changes, but as I mentioned, to make a difference, a difference has to really make a difference or it does not make a difference.
Vaibhav, I think we just heard Peter convincingly tell us that in knee replacements, as yet, it is not making a difference. Am I right? In the registry data, and unis, it may be useful. So I would think that that should be the message.
Right. So I agree. The jury is still out. For unis, the jury is very clear. I think technology has been proven beyond doubt to be an assistive technology. In TKRs, because there are so many parameters, it is quite individualistic. And once again, it's a tool, and then one needs to have a balanced view on any technology that one uses. Of course, any technology to be available, it has to be affordable and accessible. Any thoughts? So you work at a public hospital. So what do you think will make the technology accessible and affordable?
As the number goes up, number of users, and we know that there is a definite benefit which is beyond doubt, scientifically proven, I think the acceptance would be there. And as there are a number of users rise, I think the price may come down perhaps.
So just one thing which is very close to my heart, and I always tell all these company people, is that they should make their robots open source or open platforms. Any thoughts? I think that's if for any
There
technology
is
or
a,
any growth
in
to
US,
happen,
I think there is a robo which is of the,
yes, they're
the
coming
open
up,
solution.
and I think they'll be the winners.
T
But
Solutions is, I think, open sort
so
of.
T Solution is actually the QS original robot, I believe, right? But it's, yeah.
I urge the influential peoples here, like Raj Gopal, Nilen, you, who have wider contact with important people, to make a robot here so that our money is not sent out. And a corollary to that, make all implants also here. If we can send a satellite on moon and south face, which is the first time, and only on the second attempt, why can we not make this? This should be not difficult at all. And I think if you contact PMO, he would be more than happy to help you out.
Well, I would love to say, I mean, your wishes are a command, and I would love to say yes as a populist measure, but I think world has increasingly moved to an arena which is more cooperative in nature. For example, I was actually part of certain teams, and I'm still part of certain teams for designing robots. But trust me, China is so far ahead in the mechanical world that the rest of the world will take 20 years to catch. The amount of the 6-axis robot that they can build up in 20 days, India or even America can never match. The kind of software generation that we can do, the world can't match. The Americans, they can sell it to anyone. So I think the world will become collaborative. I think the mechanical part will still come from China, the brains will come from India, the ability to sell it will come from this, and the art will come from Europe. And I think that's the way the world should be. It should be open to all innovations, and the machine should be open to all innovation as such. But any other thoughts? Yeah. Yeah, please, Vikas bhai, yeah.
An excellent discussion, Dr. Weber. So when that slide comes, accessible and affordable. So this is where like we already are into making a 3D information-based software, which is known as Arthro 3D. We're not yet brought it to many arthroplasty surgeons. That software is an open source. So all it needs is the information from the CT scan that has to go into the software. And then you can decide on the implants.
I agree,
so
and you need to make it better. I think that's the point well taken.
So that is,
see,
it is made in India.
No, I think there are good
that's where we are
happening.
working on. So you can do a complete navigation on it. You can do a complete preoperative plan on it. And the next step that we have done is we have integrated that to a Microsoft HoloLens. So the HoloLens. So from what information you get into navigation and robo, only thing is you have an assisting arm and probably the arm is enabling you. That is not there. But enabling a joint replacement surgeon to get enough information to make decisions, to get into doing the right cuts can be done from that software.
Yeah, point well taken. Great.
Okay, thank you.
Training our next generation. I think this is one thing that I think there is not enough literature. Are we doing enough? I'll take these. Peter, you think we are doing enough? You work at a very standardized. Are we doing enough to train our next generation or preparing them for the next decade?
I certainly think we have left our trainees down with the COVID episode. Most of them have got really taken a big step backwards, which hopefully they will pick up. And I do believe that robots is a great teaching tool. But what is going to be even a bigger teaching tool is all the information that we gather with the robots and the prompts data to have AI giving us the algorithms to say what we're going to have to do in the future.
Now coming to a few last slides because we're running out of time. Will it and should it replace us? What do you think, Sam? Will it replace us?
Never.
Never. Never. Anyone contrarian to that? I know whether it should or not is that different question. Will it? I know no one wants us to be replaced.
Vaibhav, when I was training in UK, I trained with a gentleman called Christopher Ackroyd, who was actually, John Insall had also worked as a houseman in his unit. So he told me that to be successful as an orthopedic surgeon, you need 3 things. You need to be available, you need to be affordable, and you need to be affable. So robos are never going to be affable. They lack the human touch. And if you tell somebody that the surgery is only going to be done with a robo, I don't think people are going to take that. So we are not going to be replaced. It's a tool. We can use it if required. If we don't think it is required, we don't use it.
Great points. So, just I
was just maybe adding one point for the next generation, because coming now from a high volume house, being like trained in that way, and we are at the point discussing now, should we join the community of robotic surgery or just stay manual? I think this Congress gave me a great insight, seeing all the possible robots, what are their favors, what are the good parts, but where are the weakness yet going? And I think one point, what I take from myself in is, I'm in my 7th, 8th year of practice, I would not go earlier into the robotic knee. I needed my base surgery, get the volume up, get the hand ready. And now I think the next step is move forward to the next generation of technology, what will come. And the groundwork was done by you guys already, preparing everything. I think the next generation of machines will lead us to become better surgeons.
I think well said, and at that point I learned the future belongs to those who believe they can create the future. So just a few quick takeaways. Quest for excellence in humans is eternal, and I think we'll work together with machine to deliver what we want. And the machine data will force us to introspect, perhaps make bad surgeon an average surgeon better, and an excellent surgeon an opportunity to open doors to certain things that are still unknown to us. And the future is always at our door. And I think meetings like this, TTJR, I'm really thankful to all of you for being here, because this is how we create our future. By discussing, collaborating, debating, getting into the right ways and wrong ways. So thank you everyone for being here. Thank you. Thank you. Professor Mohit Bhandari is online, so we'll take Professor Mohit Bhandari as a web thing. And Dr. Ashok Rajgopal has to leave, so a warm round of applause for him for working so hard for this meeting. Thank you, sir, for always being there and showing us the door to the future. Thank you so much. One picture, sir, here. Sakshi wants it. And Sakshi is our photographer. She's always been capturing all the right and wrong moments. Without wasting much of time, my pleasure to invite Professor Mohit Bhandari, the Distinguished University Professor, Canadian Research Chair in Surgical Innovation, and the recent Chief Editor for JBGS. It's our privilege and a pleasure to have you here, sir.
Great, thank you very much. I'm hoping you can see the screen and hoping you can hear me.
Yes, loud and clear. Your screen is lovely. Yeah, it's there.
Okay, great. Again, thank you very much for giving me a short period of time just to chat about a large trial that we are currently undertaking, and hopefully might be able to get some engagement across India and other folks around the world. So this is basically the Prevent It trial, which is a large multinational trial on infection prophylaxis post total joint replacement. And once again, what we are really seeing with these large, simple questions is that we really do need a large group, right? The world needs to answer these questions. And if they're simple enough, it's relevant to most of the folks around the table. So these big ideas in general are by necessity simple ones, and we hope that they solve fundamental problems. You can imagine, though, that in this particular case, looking at total joint replacement and infection following that is going to require a fairly large investment of resource, time, and certainly numbers of centers. So the Prevent It trial itself is called a prospective randomized evaluation emerging novel treatments for infection prophylaxis and total joint replacement. That's the acronym, but I'll walk you through shortly, very quickly, why we think it's such an important area and why we need to move in this direction. I don't think it's not known to this particular group of members that infection rates vary, but generally can be pretty small and anywhere up to 2.5%, depending on who you quote and where you find. The costs of having a revision due to infection is pretty significant, and clearly the outcomes following infection are also impacted both with quality of life and infection, both quality of life and patient function. Our group undertook a couple of systematic reviews and meta-analyses of the literature, one looking at the effect of irrigation fluid types on periprosthetic joint infection, as well as local intra-wound antibiotics in primary care. And primary hip and knee arthroplasty, both a systematic review and analysis. And the truth is that there still needs to be a lot of work done. And so what we are doing is functionally conducting 3 trials in one. And this is using what we call a factorial design. And in principle, we want to understand and evaluate in this large platform whether or not intra-wound antibiotics versus no intra-wound antibiotics has an impact, whether a povidone iodine solution versus saline has an impact, or chlorhexidine versus saline has an impact. And the key effect issue here that we have to deal with, which is the methodological issue, is that the effects of the different active interventions are in fact independent. Otherwise, this factorial design we've developed doesn't quite work the way we'd like. We use the no interaction assumption. Bottom line is we undertook a lab experiment to assess interaction, and we found no synergy or antagonistic effects of either our irrigating solutions or vancomycin, giving us a general sense of confidence that we can indeed move in this direction. So here's how the trial would look for sites that could be interested. Is we'd be looking at basically patients come in and they're randomized in what's called a 3x2 factorial design. So they get randomized first to type of irrigating lavage, and then they get randomized second to whether they get an antibiotic or not, a topical antibiotic. And you can see sort of how it's set up here. So it will ultimately end up being these 6 groups of patients that either receive both, one of each, or normal saline. Now, we have done a successful pilot. We ran a pilot across 6 sites pretty rapidly. Within 5 months or so, I'd recruited 500 participants, and we're able to pretty quickly assess, kind of where we were with respect to moving forward. Now, we've also established a number of centers across Canada, as well as a number of trial groups in the UK. So we're working very closely with groups in the UK towards getting a second NIHR grant. We're applying for a Canadian Institute of Health Research grant. And we also have a group from Spain helping us, a large network from Spain. So here I am, but my ask here is in hope that we can have centers across India also interested. The pilot was actually pretty feasible in that we had very good compliance, right? So we had very few people who were ineligible, and we also had basically a 99% follow-up rate. So a very minimal loss to follow-up. Basically, this will include both primary and total and revision, and we're going to be stratifying for those different groups. We're going to be applying vancomycin, and we're also going to be applying 1 liter of the study interventions to each of the groups, and there'll be a 1-year follow-up. It's a frugal design in that we have minimal data collection. We're really looking at reoperation due to infection within 12 months of primary or aseptic revision of a hip or knee total joint replacement. And in this particular case, the secondary outcome will be the number of non-operative surgical site infections. So there's going to be 2 periods of follow-up, one at 6 weeks and one at 1 year. And bottom line, all we're asking is, have they had surgery? Have they had to have a surgical procedure done at that time? Sample size is 21,000 and change, but it's roughly 21,000 patients. We anticipate an aggressive recruitment of around 3 years or so. And right now, as I said, we have about 40 Canadian international sites. So we've partnered with the UK Trials Collaborative, and we are pretty far down the line, I must say. We're down to the very last call in terms of, so we've gotten through all their hurdles, and we're down to the very last call. So we're anticipating, hopefully, some positive news that 10,000 patients will already be accounted for through the UK Trials partnership we have. But that still leaves 10,000 patients that we'd like to also recruit across other collaborative sites, including Canada, our collaborative in Spain, as well as participating sites of the International Consensus Group that includes sites all over the world. So I've kept this short because I know this was added as a very last-minute presentation. I really do appreciate your time to think about this, but India's participation, I really do believe, is critical to the success, and particularly the external validity, the generalizability of the prevented trial. So I'm hopeful that if this has of interest to anybody, that we'd be able to get some support here. So we'd ask you to either contact the meetings coordinator or just let us know. And I've left my email there for you just to take a quick look at Bandam or BHANDAM at mcmaster.ca. We have a large grant going in very shortly, so we'd be looking to work with you pretty quickly if there was interest. So thank you very much.
So, an excellent presentation and a call for all of us to collaborate. Thank you so much for being here. I know you are very in close proximity to the place, and we are upset that you couldn't make it. So he's right now in India, not very far from here in Pune. And next time we hope to see you in person. If anyone has any question regarding the trial or anything, Professor Mohan Desai is here from one of the largest public hospitals in the country.
I want to ask that infection has so many multifactorial influence and so many confounding factors. Considering that, how much would be the sample size to keep the sort of beta error less? I mean, less than 80%.
Yeah, right. And so, I mean, obviously, there's always a risk of having a false negative, and you're talking about the type 2 error rate. You know, we're trying to set, like, as I said, 21,000 patients as our target. And the challenge is, if you look at other large trials that have been conducted, they're nowhere near this size, and that's the problem, in that they actually end up having false negative findings. So if there is a finding, we'd like to limit that, but that means we have to be very aggressive. And by the way, while it seems large, it's actually relatively a small proportion of the total joints that are conducted, right, and performed every year around the world. So if we look at our partnerships, or if we look at what's happened in the cardiology literature, they're recruiting trials well into the 15,000, 20,000 patient range. And they've really made a huge impact on mortality rates after, myocardial infarction, which were in the past used to be a few percent. They've got them down to well under 0.5%, right? And that's, again, we're talking about bringing, infection rates of a couple of percent down to about, 0.5% or 1% down to 0.5. But we are well powered to find these differences. And again, this has already gone through peer review in UK, and it's gone very favorable. So I'm expecting we're going to get funded, and we're going to get funded in Canada as well. And so that is the urgency, unfortunately, and the request I had of the group here was that, we are very soon going to be submitting a grant, our own final application, and it would be lovely to have 10 or 15 sites in India. And I'm actually sitting in Pune, and I'll be interacting with surgeons this evening of the Pune Orthopaedic Society for that very question, to be able to recruit more sites. So, but anyways, I appreciate your question and really understand the challenges of these large trials.
Thank you.
So thank you, Professor Nari, and hope to see you soon in Mumbai. With that, I would request Dr. Tanna, Professor Tanna, to come over. The Wisdom Studio can't be complete without someone who has the most amount of wisdom in the country, perhaps today, and that's 1.5 billion. Thank you.
First line. No, it's not here. Smile is not mine. Okay, the title of my talk is Gustake Maaf Replacement Surgeon G. Into English, if we translate, pardon me, all specialized joint replacement surgeon, but I'm going to show what joint replacement surgeon, when he treats the fracture, what happens. This was a replacement done beautifully. He was going on very well. Hip was good. Patient got a fracture. Patient got a fracture. Surgeon did properly or improperly, whatever it is, the surgery, did it with the leg screw. This was the primary surgery. 3 months, it gave way. So he did a second surgery. He removed it, put another plate, another graft. Third surgery, and this also broke down. Now, joint replacement surgeon knew how to do a revision hip. So he went ahead and did a revision hip on this, and here also still the fracture is not united, because he took it for granted that when we put in a bypass stem, it's enough. It's not enough. This can give way and the whole prosthesis can break. So if we can analyze why it failed, first and the foremost, the joint replacement surgeon, extremely good joint replacement surgeon, did the surgery of his 20-year-old knowledge. Unfortunately, he didn't involve any trauma surgeon. Now this is what happened. Possible reason, this is a short oblique fracture. And a short oblique fracture is, leg screw is contraindicated. You cannot put a leg screw in a short oblique fracture. So this is what he put in. And as you can see, this is a short oblique fracture. He put in the leg screw, so this small part of the bone becomes necrotic. This is exactly what happens. It becomes necrotic. So this is what it was done. It became necrotic, and this is the dead bone here. He didn't do anything. He went ahead and did the second surgery by putting more graft. The dead bone is a gap which I presume he should have taken out with the corticocancellous bone and put in the surgery what he did it. So this is where it is. If it is a short oblique fracture, leg screw is done in this humerus or any bone, and this is what it happens, and it comes out, and you can see there's a small sequestrum comes out, because that small piece, when you put the screw, becomes dead. So in trauma, we know it very well that short oblique fracture should not be treated by a leg screw. So now, he should have, instead of doing the block graft, he should have taken out a block graft, taken out the dead bone, taken the block graft, and probably supplemented with the second plate there, because there was a block, which he didn't do it. And here it is. This is the case which I had treated. I had done these 2 surgeries, and there is a long oblique fracture. Long oblique fracture must be treated by a leg screw. So excellent leg screws and a neutralization plate, things becomes all right. Now here is the second case, identical thing, replaced by, it was a short oblique fracture, comparatively small piece here, did the leg screw. This is exactly what happened, broke down, and ultimately the trauma surgeon treated it, removing everything, putting in a bone graft, and the things were all right. This is exactly what happens if you are not treating the patient normally all the time. Both these cases, the short oblique fracture treated with the leg screw, and bypass surgery, the patient is still walking about, but you don't know how long it's going to last. I have 2 cases which I have seen, bypass surgery, ultimately the stem bends down. Now here it is, another surgeon did this surgery for a short oblique, for a fracture below thing, retaining the hip joint. And after doing the surgery, it's a short plate. This short plate, and actually the stem is there, so he's not holding it properly. So it has been, we all know it very well, that the plate has to go right up to the GT. If it goes right up to the GT, then it can have a hold in the proximal fragment. Otherwise, it will not have a hold. So this is what it is. If you go and do a plate, because there are half plate, it will be only the locking screws, which will be half screws which will be there. So you got to go up, long plate, put a leg if you want to, but a long plate which will have probably 3 screws and it will have a good span. This is what is needed and not a short plate because that will always give way. Now here was the second case. Highly successful joint replacement surgeon did this beautiful knee and the patient was all right. Got this fracture, junctional fracture, lower 1/3 and upper 2/3. And did this nailing. Thin, piddly little nail. Even locking is not been there properly. And the fracture is so lower down. This is the part where the nail has no hold and subchondrally he cannot go because of the knee joint. This is not going to last. We knew it on day 1. It gave way. So ultimately, I went ahead, did a long plate, medial grafting, and things becomes all right. Now here, in a junctional fractures between the upper 2/3 and the expanding lower 1/3, antegrade nailing is contraindicated. Either do a retrograde nail if it is possible, or do a nail and a plate. That is the treatment for that. So if in case surgeon had done an adjuvant plate on day 1, I'm sure he would have been all right. Unfortunately, he wasn't updated enough in order to do it. Probably any one of us doing today, this is what we would have done it on day 1. Day 1, this adjuvant plate would have saved this patient. See, this is the same fracture which is treated, junctional fracture. You can see the whole thing is expanding. It can never be stability. So this is the one, ultimately non-union also we have to treat with the adjuvant plate. This is today what is recommended is junctional fractures treated with the nail and an adjuvant plate. Even if you treat it from a nail from a lower down, if there is an opening in the knee joint, still you will be a thin nail it will be. So it is advisable to put in a nail and a plate on day 1. Orthopedic surgeon's wife, so obviously treated by the best of the person in the city. Junctional fractures at the upper 2/3 femur and lower 1/3 femur where the medullary cavity expands is a poor site for the antegrade nail with 2 screws. Use a distal femur nail or a better antegrade nail and an adjuvant plate on day 1. Unfortunately, the gold medalist missed out this update and patient suffered. Tibia. He got a fracture here, plated. Where is the hold of the upper piece? 2 piddly little screws, only one-sided. There is no hold. And even the fracture like this, without the knee joint, we recommend 2 plates. Here, he didn't have even a bicortical purchase of the proximal segment. So it failed. Only thing which a joint replacement surgeon can do now is to change the prosthesis. So this is what he did. Knee joint which had no problem. Poor chap went through this cycle only because he wasn't fully aware of the trauma science at that time. On day 1, if he had put in a second plate, things would have been all right. Here it is. In even upper 1/3 tibias, we do the same thing. We never treat it with the only one single nail there. We put an adjuvant plate or a double plate, which is required. And you can see here, same thing treated by a similar way by a operating surgeon, could be treated very well with the adjuvant plate secondarily. Didn't need a revision knee at all. After TKR, now there is a fracture here. The dictum all of us know about is, after TKR, the fracture just on or below the flare of the femur, if the fracture is there, single plate is of no use. You got to put in a double plate on day 1. This is what is the primary double plating is a must. Because as you can see, this is what went into non-union, so ultimately double plating solved the problem. This was the fracture again, same way, single plating. You can see this is what is moving, because there is no hold on the distal fragment. Now here it is, because why there is no hold? Because once the fracture is like this, fracture is something like this. So when you put a lateral plate, there is only one screw is really holding it to the distal fragment. So if you put into double plating, 3 screws will hold on the other side, 1 screw on this side, so both sides it has been sandwiched. This is the treatment today of a fracture above the knee joint. If it is just at the flare of the femur and slightly below, do not do it only 1 plate, do it 2 plates. This is again a non-union treated. I remember I saw this patient, non-union completely and treated with the double plating. But you see here what has happened. This was the space. When I did this double plating, I had to compress the fracture. So ultimately, I changed the insert, made a bigger insert. I had to see that it is perfectly matching and change the insert, and the patient is perfectly fine. This is what was done. You can see the original insert was this much. It was made a bigger insert, everything was available, and the patient walked. This is when I went for my tour for the lecture. The patient, I called him in the auditorium, and this is where I have taken the pictures, so it is like this. So last, all the patients were very important doctors in their city or very important people. And just because you are a president of Orthopedic Society, you are not competent all the time. Just because you are a very good joint specialty surgeon, you are not specialist into other branches. Famous surgeons in the area. Today, I think the tendency is so-and-so has a very big practice. Richness of an orthopedic surgeon doesn't make him competent all the time. Title of a professor, director, ding, ding, ding is all useless unless he has been updated all the time. It's only the constant pursuit of excellence gives you that edge. If you give it up at one stage, you are going to be left behind all the time. And I'll quote now, last, Alvin Toffler, those who have read The Future Shocks, The Third Wave. The illiterate of the 21st century will not be those who cannot read or write, but those who cannot learn, unlearn, and relearn. Thank you, friends. Any questions by any chance?
Now you know the reason why I called the most wise man. So I think what you said is phenomenal. And if there are any questions, I doubt there will be, but if there are any questions or comments. Yes, please, Peter. Yeah.
I think for one of the last x-rays, some of the arthroplasty surgeons would have revised that. So a distal femoral fracture, we take the implant out and revise it to a hinge knee.
Sorry, I didn't get your question.
We revise this to a hinge knee. So this fracture, we would take the implant out and revise it to a hinge knee.
Why?
To have
It was possible to make the fracture heal up, and
No.
patient is perfectly fine.
to have immediate mobilization afterwards.
Sorry?
To have immediate mobilization afterwards.
This is also immobilized. This is also fully mobilized right away.
Fully weight bearing?
Yeah.
Okay.
I've seen her after about 3 years when I went to that city to give a talk. That is what I called her, and I taken this picture.
Yeah, and I think Sir has demonstrated ample time because we work with him that if you do the dual plating, your day one mobilization protocol is same as TKR.
So once double plating is a must. And if there is a gap, if it is osteoporotic, I really fill it up with the allograft because there is no autograft available. Fill it up with the allograft, and it is initially it is supported walking, but they can really walk about. There is no point of keeping 70-year-old non-weight bearing for 2 months and all.
One more question from Dr. Jayesh. Yeah, mask.
Can you give him the
mic,
mic?
please?
Sir, in the fractures which involve the flare either of the tibia or the distal femur, there are now nail options which have multiple screws other than only 2 screws. So would addition of probably 1 or 2 more screws will be enough, or it is not going to be enough for stability?
I'm sure you know I am aware of that. Distal femur nail has a good hold into the subcortical bone. While the antegrade nail, you put 5 screws, it is not supported the way the antegrade nail, the the femur nail which is supported into the subcortical bone. Still, that is a substitute. If you want to take a chance, certainly you should take a chance. I will not take.
Thank you, sir.
Thank you, Dr. Tanna. May I invite the panel and the lead for the next session before we start? Dr. Ashit Shah, Dr. Saurav Shukla, Dr. Vinay Joshi, Dr. Rajiv Thukral, Dr. Tejas Upani, and Dr. Ashish Fadnis. And then they can call the speakers individually. May I request the next panel to come up, please? You can call the first speaker, please. So you will be moderating the session. Sure. The talks and then panel.
Then panel.
Okay.
Lovely. Right. Good afternoon, friends. Let me thank TTJR, Dr. Vaibhav Bagaria, Nilen for this invitation. And we have now this last session, very, very exciting session and controversial session. So let's get on with the talks. There are a few talks followed by a panel discussion. So we have the first talk on implant and technology choice for uni, Dr. Ladda. Yeah. You have your presentation loaded already? It's already there. We have Dr. Saurav Shukla with us. Saurav? Ravi Kumar? Ravi, please. Join here, please.
May I?
Yes, please. Go ahead, Mukesh.
Good afternoon, everyone. Thanks, Vaibhav and the whole TTJR team for that excellent academics. May I ask you how many of the doctors sitting here do UKR? So hardly less than some 10 hands only. And how many of you are doing 50 per year? Even less than that. So I think this is one of the reasons why UKR is not getting that popular in our area. And we all know it's one of the most successful surgery with less morbidity. We are getting back to pre-arthritic level. We are getting good functional outcome and they can do whatever they can. As we have seen our last speaker, online speaker, he is still skiing and playing and everything after UKR. So I think the complication rates of UKR around 10% and the revision rate is little higher than the total knee replacements. The reason being, it's not taken up well by the big names in the country. They do UKR. And secondly, the surgeon who is not doing UKR but doing TKR, they have a low threshold level to revise the UKR. So some unknown painful UKR going, a surgeon with TKR will directly revise it and say that UKR doesn't work. And secondly, the numbers, as I have just asked, numbers doing 50 per year is not that much. So we have to gain that. How can we improve on it? So I think these are the two main reasons why it's going into bad name. But other thing is improper indication, which is the result, which is nothing to do with any technology, but that's the improper indication. But most other things are technical related, which leads to failure of UKR. We all know about component malposition, edge loading, polywear. We saw that case presented by Dr. Ali where he has revised the UK to TK because of edge loading, bearing dislocation in mobile bearing, then lateral compartment progression and aseptic loosening. And last and not the least, implant related. There is no implant can give any complication. It's like we are putting a good implant in a bad position which will give. So whether it's a mobile fixed, cementless or cemented. Let's go to one by one. So we all, to start with, they have some enigma or something, whether UK will work like TK. There are a lot of things, what indications, whether you need MRI or not. minimal incision, bearing surface, cementless, ideal with ACL or not. So a nice article to read how to solve these enigmas about UK, and to add on to it one more, whether you need robotic assisted or conventional TK. So to start with a unicondylar knee replacement, everyone goes through this paper, they'll get much of your ideas clear, and then you can part which indication. So the ideal indication to do UK is anteromedial grade 4OA, varus around 12 to 15 degrees, FFD not more than 10 degrees, and a correctable varus. These four are the things where you need to get, and you need to start with. Intact ACL, yes, if you are doing a mobile bearing. And then there are two types of ACL instability. One, instability leading to arthritis. And another one is ACL insufficiency or dysfunctional ACL, which you see in a degenerative type of patient. They are not really that bad ACL, but again, if you are using mobile bearing, you need to have a very stable knee. Hence, ACL is a must if you are doing a mobile bearing uni. But if you are into fixed bearing and there is a dysfunctional ACL, if some fibers are intact but patient is not unstable, you can go away with your fixed bearing uni. So extend your indications only when you are comfortable doing a properly indicated patient. Don't extend your indications soon. And then range of motions, active patient, you can even extend the age up to 65, 70 years. It's not that ideal indications. So anything where there is posterior wear on the tibia to initially start with, don't do, because this is an ACL deficient knee which you can pick up on x-rays as well. So ideally you should have a standing single leg weight bearing x-rays, correctable varus, and there should be no lateral joint line collapse when you do correctable varus, which indicates that the lateral compartment is bad. And here you see there is no posterior tibial wear, indicating that there is intact ACL and no anterior translation of the tibia. Fixed bearing or mobile bearing is again a topic of discussion, but as you see, mobile bearing is concave on concave, so there are more conformity, and fixed bearing is like curve on flat. So the conformity is not that good as mobile bearing. So what the literature says, whether they both work equally well, yes, they work, but mobile bearing has its own unique problem of bearing dislocation, which has nothing to do with implant. Again, it's an technique related, and surgeons give to the patient. Implant itself will never come out unless you don't balance it very well. So the reason for bearing dislocation, again, component malalignment, poly impingement. If your component is not placed properly, the poly will impinge onto the cruciate or to the surrounding bones, and it will sublux or dislocate. Unbalanced flexion extension gap, you have dealing much with MCL, and commonly it is seen in lateral side, because lateral side UK, the knee is lax compared to medial side. So mobile bearing has its own problem of dislocation. Fixed bearing, as I told you, it's concave on flat, so the conformity is not there, and the aseptic and subsidence is seen. But both mobile bearing and fixed bearing have same system, scoring system, survivorship, as well as complications. But then if it's so, the mobile bearing will definitely go down slowly, because that dislocation complication can be taken care very well with fixed bearing. Again, if you see, the Oxford group is the one who has propagated a lot of life again into the unicompartmental knee replacement. Hence, they have the highest number, hence they know what are the complications. Certain complications are common to both fixed bearing and mobile bearing, but some are related to the mobile bearing itself. Now, whether cemented or cementless, beggars are not choosers. So in India, we have only cemented UK so far. So we don't have uncemented. But what literature says, the cementless UK provides the same results compared to the uncemented UK, uncemented ones. So aseptic loosening is again common reason. What is the 5-year survivorship of both cementless as well as cemented UK? So cementless UK shows better clinical outcomes than cemented, but both have the same survivorship of 99% at the end of 5 years. So it may be the future, like we may get cementless UK in India soon. Most importantly now is something like technique, how can we improve, because component malpositions, intraoperative fractures, more tibial cuts, everything plays important role for survivorship of uni. The list of complications where symptomatic UK, we see most of them are related to the technique, instability, malposition, dislocations, and progression to lateral compartment, which are more technique dependent rather than the instrument or implant dependent. So we need something to improve on our technique and deliver the result in a much better way. And here where the role of technology comes into play in robotic, as a robotic knee replacement, partial knee replacement. Whether it improves the clinical outcome is still doubtful. Some literature say yes, the robotic UK improves the clinical outcome as well. But one thing which is very clear about robotic UK, that they are more accurate and precise in planning and component positioning, as well as in getting soft tissue balance well. So you can avoid all that instability issues, flexion extension malposition, instability or component malposition, thereby improving your survivorship and longevity. Still, the clinical results of conventional as well as robotic remains the same as far as outcome is concerned, but component placement definitely improves. This also, a recent article in 2023 also says the accuracy of component is much higher than your conventional TKA, which will ultimately help you to improve your survivorship in the coming years. And then high return to sports is also one of the important things which can be seen with robotic assisted UKA, we have just seen in the last talk with our surgeon, who himself underwent lateral UK and doing skiing and other things. So some of the examples, like as I say, the indications should be proper, where you have a grade 4 AMOA. The weight bearing line is just around 10 to 12 degrees of the varus, correctable varus, and this picture intraop shows only intact ACL. The lateral compartment is pristine clear, and then you execute in a proper way, cut the bones, put your implants, and this is what your MCL should be, from 0 to 120 degree, completely round, right, 0.5 to 1 millimeters throughout, even under stress. And what alignment we want post-op is around 3 to 4 degrees. So you have to recreate varus, don't get it up to center, otherwise the lateral joint progression will be more, and that is one of the reasons why unis are failing. And then you have happy patient in the hospital within a day, and even before suture removal, they get good movements and they have full range of movements, less morbidity, fast recovery. They walk home without any support and enjoy their life soon compared to TK. Another patient, similarly, you see walking day 1 and day 2 without any support, go back day 2 home, and they do all sort of things. One thing which I have improved with my robotic, these are my own x-rays, which I did one uni, you can see, sorry. What I have improved over the time, how can we minimize the tibial bone loss more, because this is the weakest link in UK, the tibia failure. So you can see this, my joint, the tibial component is way below on both the sides, but now with the thing, I have seen that my components, I am cutting it less and lesser, so that you can have almost, say, almost hardly 2 mm of tibial bone cuts. You can play much on the femoral side, and you can, even when you want to revise, it's like a routine normal TKA. So you can play much on the tibia, where you can reduce it less and have a happy patient. At the end, they can do all activities. So technology is here to help you in proper component positioning, thereby avoiding the component malposition issues. Indications is in our hand, and implants per se have no results on the outcome of UK. Thanks a lot.
Right. While we invite Dr. Karthik Shukla is here. Karthik. Okay. So next is lateral uni planning and execution. Dr. Michael. So any questions for Mukesh while he sets up his laptop? Either of them. So for how long you've been now using the technology, and what is, it was very clear that the results are getting better, but what is it? The technology. Okay, so have you used navigation before this, or?
I started with Navio in November 18 and now shifted to Cori.
Okay, okay.
Excuse me, I have a question. Do you think that you have surgeons that if they use robotic, they could be driven towards using more unis if they use it with robotic surgery?
agree to disagree with you because you need to have the basic knowledge of UK conventionally, how you plan it and do it. So same for TK. Unless you are well versed with your conventional knee replacement, you can't directly jump onto the robotics. But definitely robotic is helping us now to enhance and do more of uni because we know we are able to deliver it in a better way.
Yeah, the reason why I'm asking is because there's now evidence that if you go to the NJR, where you can see the data of surgeons that are using robotic, and you see people that are not using robotic but have been doing a lot of unis in the past, they are basically still outperforming the quality of the robotically assisted unicondylar replacements in quite a few numbers. So I think that it's very true. I would agree with what you say. You have to learn the basics, but if you start to do more unis with just robots, then it's not going to work. I agree.
Correct. So it again also depends on the volume the surgeon is doing, the number of cases per year. So, typically as described by the Oxford group, it's around 40 to 47% of the cases you can do uni, but we are not doing uni enough. But if a surgeon puts his mind and he starts doing this uni in the ideally indicated cases, with more number, he becomes more and more accurate in doing this surgery. Can you have the mic again, please? He wants to make a comment, please.
Ashit, I think this has been claimed again and again. There was an article from, it is I think in JBSJS American group, where a high volume surgeon did that. And he found that despite being a high volume surgeon, he had a higher failure rate when he was doing unis. He put in Oxfords and finally stopped putting Oxfords. So that article is also there, which is not really getting as much prominence as what the Oxford group is promoting.
I mean, obviously for the reasons.
No, he was high volume for the TKs.
But it should be 20% of his knee volume should be UKR. He was high volume for the TKR, not for percentage of UKRs that he was doing out of those knees.
I think he was high volume for TKRs. He did a high volume of unis also of that, and he still found that there was a higher failure rate. So I think all the people who are doing unis, if they get a high failure, and the thing is that even I am doing unis, but we should not be married to either uni-compartmental or total compartmental. We have to see what works in our hands, and even a total knee replacement will give similar results if done properly.
Correct. Yeah, you want to make a point?
Yeah, I mean, I was referring to surgeons that actually use a robot, and they are doing a fair amount of cases, even then, more than 40 per year. So my concern is really that these new technologies are going to drive surgeons to actually modify their indications. As you were pointing out very, very rightly, you have to have the correct right implant.
Correct.
So there is a trend now also in UK to actually move away from the mobile bearings, because people see that the fixed bearings are doing better and look more at the indication. We have a very strong trend in Germany right now to actually say you can do 40% of your knees as unis, and I would strongly disagree with that.
All right. Right, okay, so we'll move on with the next talk. So let's talk about lateral uni, which is even rare in the uni group of surgeries. Michael.
Thank you very much for the invite. Yeah, my first question right away to the audience: who is doing lateral unis? So like the number like we had before, the hands up for the medial and the lateral is very rare, but for fairness, the lateral compartmental osteoarthritis is also, or the indication is much more rare than for the medial. Let's go back a little bit in history for the unis in general. Like the unis are already there for over 70 years. The concept has changed a lot, and the current concept, how we use it, how the implants, is more from the 90s. The current concept with the bearing is again the fixed or mobile bearing, like the discussion we have. There was a switch more to the mobile bearing. Now I think we see across the world more the move to the fixed bearing, because people leave the Oxford. What is the indication for lateral uni? So again, we have the clinical examination, which shows that it's just the lateral side involved, the lateral pain, flexion higher than 90 degrees, and no more extension deficit than 10 degrees. I purposely didn't include a varus degree, because you're going to see in the literature, some people say maximum 5 degrees of valgus, some people we saw today, my colleague earlier, up to 15 degrees. And I think that number is really, you can't fix it in one position. It has to be a clinical examination where you put the indication.
The ACL, my colleague previously showed nicely, I don't see it as a fixed criteria, it's a relative criteria. You can have an insufficient ACL that's compensated muscular, but you can have an insufficient ACL that is clinically unstable. And those candidates you have to take out. Previous surgery is not a contraindication. The first indications, if you were looking at unis in total, they were saying a previous HGO is a contraindication for a uni. It's not anymore. So important is have a correctable valgus. You can correct the deformity, otherwise you're going to overload the other part of the joint. And what do you need for diagnostic? A lot of discussion was happening, do I need an MRI to diagnose it? I don't think so. You can do the diagnosis with your clinical examination. You need a full leg picture, you need 3 views, but you also need the stress views for the knee. Data a little bit why they were failing. Why is the uni? On the right, a little bit 10-year-old data, and it's a general. Again, the lateral uni is so margin in the whole numbers that you can't really find specific data just for the lateral uni. But the aseptic loosening and the progression of the osteoarthritis are the main reasons later on for revision. The pain is always something in between. It's sometimes an not diagnostic loosening. It is a progression of OA that's not seen. The pain section, the 20%, is really difficult to put in one category. And as my colleague mentioned before, this is data from 2021. We see in Germany a switch from mobile bearing to fixed bearing. We have right now 89% to 11%. This includes TKA and UKA. There isn't, unfortunately, in the data, there's no specific. And of course, the increasing use, just to jump from to 2021, we had 13%. The year before, we were just at 9%. So the indication, as we talk, is getting brighter and brighter, and more surgeons are going for the unis. And the cemented, most unis are cemented. This is 90% of cemented, again, for the whole knees, TKR and UKA. But I would say the number is even higher as you just say UK medially or laterally. It's all cemented. We had the uncemented Oxford. We noticed an increased rate with or a higher risk for fractures of the tibia plateau. Just how you need to impact the implant is putting that small surface more at risk to fracture. So how do we proceed? A little bit the technique. I have drawn the medial incision in black and the lateral incision. As previous this morning showed, it's very important not to split the patella tendon. The capsule on the lateral side is much, much thinner than on the medial side. So you're going to be through the joint much easier. There is a nice PET pad. You always notice lateral of the patella tendon. And when you get into that by cutting, you know you're getting into the right size. As for the positioning and the cut of the femur and the tibia, it was well mentioned today that the tibia on the lateral side has a total different shape than on the medial side. Nevertheless, most of the implants are basically just a reverse right medial, left lateral, which is sometimes difficult to mimic in the perfect positioning. So Zimmer went that far that they have the PPK, the persona partial knee, which is more identified just for the medial, and the lateral is about to come on the market, which will be, I think, a changer and a helper, especially when you try to position the implants, very important. As for the first cut, the vertical cut is very important too, because it's different to the medial. When we go with the saw on the medial side, we try to stay in the upper coming part of the eminentia, stay as close as possible to the ACL to avoid impinging. On the lateral side, it's different. As my colleague mentioned before, the femur will be very lateralized, your femur component very, very lateralized. So you cannot put the tibia too close to the medial, otherwise you're going to have edge loading of your implant. Because the tibia plateau is so small, you cannot increase the plateau in ML size, otherwise you will be overhanging AP size. So the cut should be much closer to the lateral edge of in the notch to the lateral edge of the femoral condyle, not to be too close medially when you orientate. As for the femur, it's pretty much similar than on the medial side, even though the shape is different. The cutting jig is very similar. But it's very important to keep the edge on top of the femur about 2 millimeters. If you go too close to the edge and you remove later on your osteophytes, or the osteophytes will resolve with time, you risk to expose your top part of the femoral component, and this will create later on pain on the patella or even engaging in the patella. So mostly for the technique today, I brought you cases I've done recently in the last 12 months and to show you just how wide and different the indication can be. First case, pretty easy, pretty straightforward in the way that clear valgus, 61-year-old woman, only comes with lateral pain, no major side effect, 2 previous surgery, and that's mostly the case what you hear for lateral unis. They don't come with primary osteoarthritis, they had mostly surgery done before, and it's mostly a meniscectomy, because that will lead to this rapid progress of the lateral osteoarthritis. And this was the case here, and she was just reduced in pain. But what was important to see, when you do a full leg stand, unfortunately I didn't put it on, but you see it on the full leg, the lateral compartment when she stands is not collapsing. But when you do the stress X-ray, you can see how the lateral compartment collapses, and she is basically bone on bone. So she went on to receive surgery, and you can see on the X-ray, it's similar. So what you always tend to the X-ray, and that's going to be difficult with the technician, you always try to see how is my tibia plateau aimed. It is different on the lateral side. You will always have the feeling it's too much posterior, but basically it is on the edge. It's not overhanging it. And you will think, oh, I should have put it more anteriorly. It's not the case either. It's just how the anatomy of the tibia plateau is, and joint line reconstruction pretty well. So we're going for another case, a 52-year-old woman. And again, the similar story here. Previous arthroscopy, meniscectomy, but again, the axis is not really in valgus. Because of her tibial deformity and S-shaped tibia, she's basically a straight knee. And this is cases where most of the surgeon would not say, oh, that's an ideal case for a uni, because her valgus is very, very small, and I risk to overload the medial compartment. So in these cases, I really go talk with the patients, what is the best solution, what is her expectation. She's young, she's 52 years old. So whatever decision I take with her, it's for the next 20, 15 years, because she's going to be coming back to me. And again, the stress riser showed nicely that her lateral compartment is basically collapsing. When we do the same images for a medial osteoarthritis, we see nicely how the joint is held up on the lateral side, but she has bone-on-bone contact there, and the pain was really limiting her. So I went on and performed and tried not to overload, I resected a little bit, maybe more on the tibia, tried to restore the joint line, but I kept her in a straight line. I measured later on. She didn't went on to varus, and she was very happy with the result. A last case, and very, very interesting how to show that a preoperative case is not a contraindication for valgus, is a post-traumatic case. Again, a young woman had a ski accident, had in 2020 a tibia plateau fracture, which was treated with a bilateral plate. My colleague before would be happy for that to see. So she went on to heal her persistent pain. So they removed the material in September 23 and came to see us this January recently. So she had persistent lateral unique pain. And I think when you look at the full leg standing, she has the valgus. It's a valgus due to a trauma. But as you look at the pathology, she's collapsing really just on the lateral joint. And the lateral joint space was never fully reconstructed. It's damaged. Of course, there was a pre-op infection lab done, because postoperative trauma cases are always at risk to have a trauma case. So she's very recently operated. She was up and running. It worked very well with the tibia plateau. And now with the joint line somehow reconstructed, I can't see that the medial space is now overloaded. It's going to be interesting to see how she progresses. It is, of course, damaged bone under, but for the small tibia plateau in this case, and because it's cemented, it's holding very well. So thank you very much. Any of you have any question?
While we ask the questions, can we get the next speaker, please? Is Dr. Kalevan here? Kanan? Yeah, please go ahead. One. Okay.
Was there any time that you had decided for the lateral uni preoperatively based on clinical examination and radiology, and then intra-op you had to change the decision to do a total knee?
In lateral unis, not once yet. In medial, once.
Okay.
In literature, what are the results of lateral uni? Because, you know, when you go across the literature, the medial uni, the results are very well described, whether conventional or robotic. But what about lateral uni? When you do it conventionally, this is conventional, or the robotic?
It's all conventional. There's no robotic.
Right. Okay.
So that's the issue we have with the lateral uni. It's always in registry data, or even the German in the international, they all mixed with the medial unis. So it's all in one part, and the data is talking for one part. You can barely find specific any literature that has recently even come out specific just for the lateral uni how well they do. So we have to estimate that they do well with. And looking at the Italian group who is doing the bilateral unis and performing very well with ACL and PCL sparing, I guess the lateral uni will be still. I think it's very interesting to see specific lateral uni results, but because we have so many indications, strong valgus and a different way to go, it's going to be hard to say like if it's just one success rate or if you have to be more specific.
The way you analyze your stress x-rays for a medial uni, we see that the lateral side doesn't collapse. Yes. But in your x-rays, quite a few x-rays, stress x-rays for a lateral compartment, there was a collapse on the medial side. Still, you've gone ahead and done a lateral uni. Does that not scare you? Or
so if it collapses a little bit, it shows that there might be, and it's just because of the difference of the anatomy and then how the cartilage is. As long as the patient is pain-free, I have an open discussion with the patients. Always, if I decided for uni, I tell them, we decide for this because it's the best clinical results, and I hope I have to give you for the next 10 years, even though the uni results are great at 15, 18 years. But the goal is like, talk with the patients, what are the expectations? So, and if I can provide you a solution for the next 10 years at least, then I'm happy to proceed. And when the patients say, well, I read it's very bad and I don't want it, then that these kind of patients, I would not be very keen to do a uni, and I will tell them, okay, we will go on with a total knee.
Thank you. Any more questions? Right. Thank you very much. So can we invite the next speaker, Dr. Ravi Kumar, please? Tips and tricks of the performing of flawless Mako image-based robotic uni.
Yeah. Thank you very much for the opportunity. TTJR team headed by Rajgopalan sir and also Bagaria sir. So, and I'm very proud to be here in front of my one of my professor of my initial days of joint replacement, Dr. Professor Wolfgang Klauser in Endoclinic, under whom I was trained, and also Thorsten Gerke sir. So these were my gurus in my early days of arthroplasty. Thank you for that. Coming back. The most important criteria or the tip and trick starts before the surgery. As I mean any of the surgery, it's a patient selection. So unless until you find a proper patient, especially in a country like India, the rules of the game should not be forgiven. At least 100 unis you do, unless until you vary or you change your indication as per your surgical techniques. That should be bone-on-bone arthritis, enteromedial, and full cartilage intactness on the lateral side, intact ACL and MCL. So once we have that, then the definition of AMOA, we did a small study where we did around 167 joint replacement surgery, and clinically and radiologically, preoperatively, radiologically we predicted this may be an AMOA, and intraoperatively with a second observer, we found the incidence of AMOA is quite high in the patient whom we are doing total knee replacement. It's almost, we found 23%. So among these patients with all the criteria needed, I'm not telling everybody has to undergo unicondylar knee replacement, but at least the patient who definitely had indication and AMOA, uni should be a great solution. And as we know, there are mobile bearing, fixed bearing, and today my talk is about more of robotics. So what Mako do? I mean, everybody has to undergo definitive training in conventional unicondylar knee replacement, as Ashish sir told and many of the faculty told. But what additional robo can add it? So we have enhanced planning preoperatively, where you can understand what are the size of the implants we're using, whether these sizes are adequate, because we have already a CT. So most of the failures are not technique related when they do at least 100 unis. Most of them are also not improper understanding of the implant size, whether it fits. To our surprise, most of the uni with persistent symptoms, we have upsized the femur. So that means with a CT, if you understand 70 to 80% of your distal femur is covered, or if it is more than 80%, Then it is upsizing. So upsizing of the femur always causes persistent of residual symptoms or unhappy uni. So you have an option of dynamic balancing where you can capture in multiple poses like 10 degrees, 45 degrees, 90 degrees, and deep flexion of 120 degrees and balance accordingly. And also we have a haptic guidance so that we can avoid injury to the vital structures. Rather than telling what are the tips and tricks with my short experience, I thought I'll demonstrate one of our case whom I video shooted so that you can understand the basic steps of the Mako. A 45-year-old gentleman, his infective workup was normal, and this is how he was walking with a gait, and this is the stress view, Rosen view X-rays. So the major criteria is bone-on-bone arthritis on the medial side, and lateral no collapse on the valgus stress. And then we go to the workflow. Initial is preoperative planning, that is the what size of the implants, whether the implant is overhanging on the lateral side, or the base plate is appropriate, are we big enough for the distal femur. All those criteria, including the base plate in all the 3 sections, we have to understand. Then the proper array placement, then the proper bone registration so that the bone anatomy matches with the CT anatomy, so that it can give a live double check mechanism. Then you capture the gaps in multiple positions. Minimal of 4 positions, more positions also acceptable. More the position, more easy to balance. Then do the cartilage mapping, whether your distal tip of the, the proximal tip of your femur processes is under the cartilage or is it overhanging. And then do the implant tracking. This is an additional feature where any of the technology can give you, whether your implants are sandwiching in all the poses, 10-degree extension and 45 degrees, 90 degree and deflection. The trick is both femur and the tibia should get sandwiched, and there should be some visible green space on all the poses. And finally, bone preparation, which is quite easy. Let's go step by step. The position of the should be important. Then do a regular arthrotomy. I do a little bigger arthrotomy compared to others because I don't want to miss on any of the findings like ACL integrity and lateral condyle involvement. So some people do a minimally invasive that doesn't matter in the outcome of the patient. So then, so then you can see here, you can visualize on the both sides. My criteria is there should be bone-on-bone arthritis on the medial side, and there should be pristine lateral compartment, and ACL should be intact. Then we do the array placement both on the medial side and also on both sides on the tibia and the femur, appropriate enough so that when the extension they don't collide with each other. That's a trick. And then put a checkpoint for the tibia. And if it is an intra-articular pin placement for the femur, I don't use a checkpoint on the medial epicondyle because most of the time it gets missed during the surgery or it moves when we're doing the burring technique. So, and once again, you have to re-registers and all those things. If you are using only extra-articular pins, then definitely there is a need of intra-articular checkpoint for the femur. Once you do that, the bony registration has to be done after the landmarks. First is hip center, then is medial epicondyle, medial malleoli, lateral malleoli, and joint center in the tibia. Similarly, in the femur, we do the checkpoint on the femur and the medial epicondyle. And once we do that, so in this case, the slide is a little mismatched. I remove always osteophytes after I do the bone registration, especially the city-based robos need that we have to remove the osteophyte after we register because it gives wrong values because the osteophyte was already included in the CT scan. So once we do that, then CT planning, check all the sagittal, axial, and coronal planes, whether your femur and tibia are appropriately sized, whether they are overhanging, underhanging, how much is the bone remaining. The trick here is, as soon as we have this image, take the green probe, there is a sharp probe and the blunt probe, take the sharp probe and keep it on the medial side of the implant. So, and capture it. If you're capturing, if you're on the bone and you're outside the green purview line or the magenta line, then your size on the medial side is appropriate. So on the femur, and also the check on the anterior aspect of the femur processes, if you're on the cartilage and you are above you have left with some cartilage on the distal aspect, then your femur size is appropriate. So don't overhang on the medial or the lateral, especially there is a high chance we avoid erring on the lateral side. Make sure that we should not cross the notch. So then we do the registration, 40 points on each side, tibia and the femur, and there are some checkpoints, so that they're called as confirmation points. Once we confirm, our accuracy should be within 0.5 mm. So the accuracy is very important. If you are beyond that accuracy point, cutting angles and everything will change to some extent. So even though they say we accept, don't go by them till we do a minimum 100 cases, don't change anything, be in the acceptable margin. So that is the second trick. So then once you do that, the tibia registration also remains the same. The accuracy on the tibia is always sure around 0.2 to 0.3 in my case, because it is very easy to register. Femur, it ranges from 0.3 to 0.4. I never cross 0.5. Or if it is 0.5, I redo the bone registration, so I want to be in safer boundary. So there is always a variation of 0.1 mm digitally, because it is a superimposed anatomy from the CT and also the bony anatomy. So these are the very important points. Once we do that, then we have to check the implant positioning and implant tracking. This is the greatest advantage of the technology, where clinically we cannot anticipate properly. So here the red mark should always on the femur and the tibia should overlap each other, and the deflection you have to, when you capture the both should be superimposed and sandwiched so that visible margins are seen in all the positions. So this implant tracking is an additional feature what is there in the implant tracking has to be appropriate for the implant related failures to prevent. So once we do that, then once again you cross check in all the poses, even in the deflection. Then if you have any issues, you can externally rotate or internally rotate under the acceptable range of around 5 degrees, so that your tracking will be better on the femur. So the more trick, the previous speaker, Dr. Loda told, so don't work more on the tibia, especially in the unis, especially in the Indian scenario. So small bone, osteoporotic bones, and so if you cut more on the tibia, the chance of fractures and issues of so many things will be there. So work more on the femur. You have 3-dimensional way of rotating, flexing anteriorly, posteriorly, flexion, extension, and the gap balancing can be done more with the femur. So you should be have these all for curvature should be always matching. You should be proud 1 mm distally and posteriorly. You should have appropriate size, and there should not be overhang, and the balancing should be in all the poses. So other tide mark is that what I was telling, the tip of the implant should be marked with the green probe to check you have enough cartilage left for the patellofemoral articulation. So we have to, as I told, we have to capture in multiple poses of 10 degrees, 45 degrees, and 120 degrees, so that we have different capture poses, how much immediately we're opening by cranking it. So once we do that, so we get a gap like this. So you can see here, so it should be around 0.5 to 1.5 mm loose in all the 4 poses. So one of the pose it is little tight, so we have to change our implant design as per the balancing method and get all them to acceptable range of the balance. You can see the graph now. So once you do that, then the job is very easy. They do a cartilage mapping once again and check for the superimposition once again and check for the tide mark once again and go with the bony preparation. In the Mako, we can cut the tibia and also perpendicular tibia cut and the posterior condylar cut with saw. So and then remove the biscuit. Trick is the posterior condylar femur has to be removed first, then tibia anyway, it is one more cut is remaining. Then do the distal resurfacing with the burr, and the burr holes also are directed by the software, and do the burr hole, 2 burr holes. Then clear the ACL bed so that the tibial biscuit can be removed. Here care should be taken that you should are parallel to the green line where you are going and not injuring the ACL bed. So still in my book, ACL integrity and MCL integrity and intact lateral cartilage are the indications for uni. I don't want to err on the higher indications of the unicondylar replacement. So that a country like India, we should do the best because they come with so much trust and less resources. Once we do that, then do the tibia with a trial, put the trial fixed bearing insert, and then the femur, and check the dynamic balancing. So in the dynamic balancing with the axial load, you have to flex from 0 to 120 degrees and capture everywhere, whether you are on far with the the previously balanced gap balances. So then we do all the flexions in all the 4 positions and match to the previous position. Then check the patellar tracking and the interposterior instability and also medial lateral instability. As discussed by the previous thing, we should always undercorrect the varus. If you overcorrect the varus, the progression of the arthritis to the lateral condyle is not prevented. The whole idea of doing a unicondylar knee replacement is to arrest the progression of the arthritis. So if you bypass any of the laws of the rules of the uni, it is going to fail. Technically, it's a definitely challenging surgery compared to knee replacement. But if you well done either by conventional method or using a technology, we should get a great results like this. So after the completion, we can check in all the angles how is implant tracking. A well done patient, a former where I do OPDs outside in 2 tier cities in a month. I go and saw him. I failed to understand the recovery. Okay, so to conclude, patient selection is the key. That's most important, and clinical assessment is the next important. Intra-op assessment of the implant tracking and appropriate positioning, both tibial and femoral components, are more paramount, which can be easily done with technology. Gap balancing, error on keeping it a little loose, and tight flexion gaps, they were usually unhappy. Stepwise algorithmic way of doing a UK with a technology-based, especially the city-based UK, provides a great solution. And the previous speaker showed the base plate is becoming more and more proximal, less bone loss on the tibia, and so many advantages. With this, I thank once again the TTJR team, Bagaria sir and everyone, and Dr. Gaurav for inviting me. Thank you once again for the opportunity. Thank you, sir.
Thank you. Thank you. Any questions for Dr. Yes, Manan?
When we are using either of the robots, can you decide exactly how much varus you want to keep the knee in, or is it decided by the balance? Because I was seeing in your slide that you had planned for 2 degrees. It was showing you after your trial around 5 degrees of varus.
Yeah.
So do you make the tibia thicker, redo the distal and posterior cuts to get back with a larger poly to 2 degree varus, or do you kind of just accept 5 degrees? And what is the real consensus on how much varus how much should you change your varus from what the software is suggesting that you accept?
I mean, you can change to any extent, but acceptable range, what are the indications, what are the recommendations are? Yes, sir.
No, after you
answer the... Yeah, 3 degrees of varus, 5 degrees of flexion and extension, 5 degrees of rotations in the femur. But this case was, unfortunately, it was, because I had a video of this, I demonstrated this. So I wouldn't have accepted the 5 degrees there.
So from 2, if it becomes 5, then do you redo the femur, or then how to go about that with the robot?
Yeah, you can, at any given point, we can redo it. We can rebalance and change the majority of the changes, let it happen in the femur. If you are not able to balance the femur, you can take the tibia up and down and balance. And most of the time, non-removal of the osteophytes, especially in the posterior femoral condyle, would have also contributed for the tightness. If you remove that, most of the time it will be fine.
Okay.
I have one question. Can I ask one?
Yes, sir.
So in the planning, we have those candidate zone. One is central, then zone 1, 2. So where in a robotic, when you are doing a robotic UKR, where do you plan these axis? Going through the zone 2 or in the center? Where do you plan it to be?
Yeah, in the center most of the time, sir. But due to, unfortunately, the femoral condyle variation is so much in Indian sub-scenario. So the care should be that we should not laterally overhang, and you should not medially overhang, and you should not anteriorly overhang. These concepts, as there is a 3D...
You plan it to be center,
yeah,
not in zone 2 or so?
Yeah.
Okay.
So may I add to it? This slide is shown on the planning how to avoid that edge loading.
Correct.
The way you are telling. So if we see that the femur and tibia, the points are not in the center, you can either shift the tibia a couple of millimeters more medially, or you can shift the femur, so avoid that edge loading on the planning stage. And to add one to Dr. Manan's question is, if you see, it also depends on how slightly, even if you are holding it in little more varus, the leg, it will deviate by a degree or two. So try to be as neutral as possible, and all the systems have a chance in trial. If you see from 2 to 5 you have gone, you can redo on your planning stage and assess where you have gone wrong, or you can make those minor changes. But definitely the post-op, what we accept is around 3 to 4 degree of overall alignment.
Right. Okay.
Thank you.
So thank you very much. That was an excellent discussion. So now let's get on with the last session of the talks and everything. So this is going to be a panel on why robotics in uni, because we know it's a very controversial subject and there are a lot of things that can go wrong. So let me get my panel. There are a few people who have left already. So can I invite Ravi? You stay back, please. Can I invite Dr. Mukesh Ledda? Please join the panel. Dr. Michael Sostem, please. On the panel, you are filling in for someone, and Professor Mohan Desai. Come on the panel. See, the way we've selected now this panel is we have equal distribution. 2 of the surgeons are using robot, and 2 of the surgeons are not using robot. So we have a balanced panel here, and I'm using a robot, but I don't still have a software for UCare. So I'm going to be sort of a neutral person. So let's get on with a few burning questions that I'll ask you, and then we'll go ahead with just give the mics, please, here to all the panel members. Right. So as we all know, and we've been listening for last half an hour and last couple of days, is one of the most successful surgeries. Patient-reported outcome measure favors the continued clinical use of UKR, and the forgotten joint score in UKR is much higher as compared to total knee replacement. The procedure, as Dr. Mukesh Ledda just mentioned, is still not very commonly performed by even arthroplasty surgeons. Higher revision rate across most of the registries are seen, especially the Swedish registry, the Finnish registry, etc. So let's ask our panel, why do you think there is a lower incidence of acceptance of this procedure? Let's start from Ravi, because Mukesh has partly answered in his talk. So let's start from Ravi.
It's basically, I will tell my experience. People vary from vary. And when you tell the patient uni, the first question they ask, is it a stopgap procedure or is it a permanent solution? The first question. Second question is, most of the uni patient, they will have, even though bone on bone arthritis, they have minimal symptoms. They want to wait. That is the second thing. And it's not that surgeon alone don't want to do. And third thing, it's our change of practice also, a little, little changing of that trend of doing uni also is little less in Indian sub-scenario. But if you do a proper unicondylar replacement, it should survive for a long duration. It may not be a stopgap procedure.
So let's put it that way, that the patient is ready for whatever surgery you as a surgeon would tell him.
Correct.
Now, still there is low acceptance of this procedure. So what do you think is the reason? Because the patient population that we see and people in Europe and US are totally different. Correct. So what is your take on this?
Take is, if the patient is ready, if somebody is trained, definitely he want to do it. But probably the training is for the UK is lacking as compared to the TKR. Okay. So I think training, if it is improved, I think people will do more and more.
Sure. Michael?
Definitely, if you're just able to do a total knee, don't do a uni. If you don't do it often, and if you're not trained. I think indication, patient selection is really important, and I like to use what I so-call the one-finger test. If the patient shows me on the medial side, that's my problem, I can do a uni. If they go like this, I have pain here, I'm not going to do a uni anymore, although those radiographs, the MRI, might show me a different direction.
Right. Professor Desai? Mohan?
I think acceptance among the surgeon may be less because of the registry data. The overall survival of unis is not as great as the TKRs. But then I have been doing the unis the manual way. Right. I have not been doing robotic, and I know I have tilted more in favor of the fixed unis because of few problems of spinouts of the Oxford. So we have been doing it.
Not only the arthroplasty surgeon, our routine general whole orthopedic team in the city should be telling that UCAR works. Like if suppose in a city 10 arthroplasty surgeons are there who are doing joint replacement, but there are 90 who are general orthopedic surgeons. So patient not only takes suggestion from arthroplasty surgeon, he goes to other doctor also who is not into plastic. So he says, "Arey, uni to time pass hai, it's beach ka gap hai." So that education has to be gone through our whole orthopedic fraternity that uni works.
Yes.
And when 10 doctors start saying to one patient, yes, you need uni, I think the numbers will slowly grow. And second, acceptance by ourselves. Yes, uni will work and I'll do uni in this patient.
So it's again boiling down to the skill amongst the surgeon and our ability to explain the patient. We have to really train ourselves hard in whichever way to master this particular technology so as to be able to offer this. So yes, Michael?
I think if you look at the revision rates, why do we revise the unis? Because they're easy to revise. Why do we not revise the TKRs? Because it's more difficult.
Correct. Yes. So, yes, Mohan.
For the Repeki, in fact, described this as arthritic, outpatient arthritic bypass procedure. So for a young patient, it may be a stopgap procedure. For an elderly, it may be a definitive solution. For elderly, it may be more useful because it's less morbid.
Yes.
Perhaps I would be more comfortable in doing bilateral simultaneous uni than I wouldn't do a bilateral simultaneous total knee replacement because of whatever, because I am doing a manual way. I am not doing a robotic. I open the canal, chances of fat embolism and all that. So for a elderly, it may be the final solution.
Right.
So it depends.
Right. What do you think is the literature support for us to explain the patient or to explain ourselves and convince ourselves? Because when we go through registries, we see the failure. So we are also sometimes worried that 4 or 5% failure rate in finished registry at 5 years. This is unacceptable to any arthroplasty surgeon. So what about the literature support? What do you think, Mukesh?
So definitely literature support is much better for TK survivorship and complication. But again said so, when you are convinced, yes, you have that capability of doing it, the complication rate of individual surgeons varies. And then secondly, I feel as we keep improving on technology, and as I say, as sir told, younger the patient, maybe a stopgap, but if we are doing TKR in a 50-year-old patient, we know he'll definitely come to us around 60, 65 odd for a revision. And converting a total to retotal, we all know is a painful job. So it's us how we can tell the patient in younger population that yes, it's a must for you, then rather than older population which comes around 60 with tri-compartmental or even 65 with only partial, I may suggest a TK because I know that's a lifetime procedure for them.
Sure, sure. Michael, anything on the registries that you've gone through and then you realize that something is different and something is amiss?
I think I'm just going to say the same thing again. It's easy to revise.
Sure. Okay, right. Easy to revise, so do it. It's like a typical orthopedic surgeon. You have a hammer, you'll find a nail to hit it.
Especially on the femur side, easy to revise the options, the uni revision. So, even though it survives for around 12 to 15 years, that should be quite good stay for the, good survival for a UNICEF.
It is easy to convince the patient if you wish to, sorry. So, if the patient is told that yes, after the uni, you can squat, sit cross-legged, you can do anything what you want to do. But after the TKR, I would warn you not to do it. You may do it without my notice or. So they are very happy. Indian patients, they want this activity. So it's a truly kinematic. They are easily convinced.
Sure. Dr. Neelan wants to make a comment.
Yeah, Ashit, what I tell my patients is that I feel that you are suitable for a uni. I would like to do a uni, but if you look at the overall literature rate, there is a slightly higher failure rate for unis which is there, but the success rate of unis is also higher than the success rate of totals. So a successful uni is likely to perform better than a successful total knee. So if you want to go for that, that is what I would recommend, but I accept that there is a slightly higher failure rate for unis which is there.
Thanks. Right, so that brings us to the next thing. Conventional UKR Where do you think is the area of deficit? Let's see, Mukesh and Ravi, they are not still doing the robotic. So you are still in the conventional phase. Where do you think was the main problem of doing a conventional and why you jumped onto robotic now? So you can ask on this three, ask the alignment, mainly it's been spoken and we know that it has to be an undercorrection, slightly undercorrection. How would you achieve an undercorrection by using manual instruments?
So the manual I would put with those Kennedy Peterson zone.
Right.
So I will feel safe that the mechanical axis would pass through zone 2, slightly medial to the center, and because if I am planning to go through the center mechanic like TKR, then it is possible that I may inadvertently at times it may go to the lateral side, which is day 1 failure.
So how do you make that sure clinically, on the table, because you don't have the technology to tell you that whether 2 millimeter here or 2 millimeter here is going to change your mechanical axis. Now, uni will take that, much less than a total knee. Total knee, you can, even if you err a degree or 2 or a millimeter or 2, it probably will accept it, but uni will not. So you want to be exact, and how will you do it? Manually, because you're doing the manual instrument as yet.
Manually, just stay medial to the medial tibial spine. So that you don't shift it more medially.
Right.
It's in the center, then you are going more away. Secondly, don't touch MCL at all. Just remove the capsule so that you are not opening it much and you are not putting a thicker poly, then it will shift. So minimum bone cuts, be just medial to the medial tibial spine, and then no big poly will be the key to get that into varus.
Yes, Michael, anything else you want to add?
And I think we have to bear in mind that it's a different philosophy in unis than in TKRs. It's more gap balancing thing. And it's not just like your bone cuts.
Sure. So, correct. So that's what the last thing is. The gap balancing is the crux of the UKR. Ravi, yes?
Sir, conventional also doing very extremely well. Many people we have also done. But this technology definitely adds a quantitative analysis of gap balancing, which is the most important factor of a uni outcome. So I think that has added additional advantage in our practice with robotics.
So what about rotation of the femoral component? In a manual that we've been doing, sometimes you can err on the side of external rotation. We saw a couple of intraoperative slides today which failed early. So how do you manage to get it? Though there are instructions given in the manual, but still many a times you see that doing manual femoral rotation is the most difficult thing to do, second only after the tibial resection. So tibial resection is most difficult to get perfectly right in a manual, second is a rotation. So how do the panelists do it? Michael?
The tibia drives my rotation of the femur. I do the tibia first, and then I decide on my rotation of the femur.
Okay, right. Which system do you use, Michael? Can I ask? Which?
The Persona partial by Zimmer.
Persona Zimmer, right. Okay. One.
The fixed bearing, I have used the PFC partial sigma. I have also used link. Link for the femur is totally freehand, just scraping of the cartilage. And in a PFC, you know that for the femur, you put in that spacer there in the on the tibia after having a tibial cut, and then put in that jig. So that way it aligns to some extent. Right. And
okay.
And in the Oxford, you have that the microplasty instrument where you put in a central rod, which and there is an alignment, so it aligns it to some extent.
So getting that center point is really difficult because it's eyeballing where to get it.
Correct.
So what I do, I just take the rough size you get, a type 2 femur 3, and just play it in a reverse manner to see how exactly it's feeling after removing the osteophytes, so that you can get that little curvature initially itself.
Sure. Right. Okay. So gap balancing, again, it's been discussed. That's the main important thing, that how you get the gap balancing.
It is different for the mobile bearing and the fixed bearing. So fixed bearing, you would keep in flexion, you would keep it lax, but absolutely tight in the extension. But in the mobile bearing, you have this, you match the flexion and extension perfectly. We don't want any mismatch.
And on the design of the process that you are using, because the conformity is high in the mobile bearing.
So flat on, round on flat in this, and fully conforming in the mobile bearing.
Correct.
Makes a difference.
Okay. So again, this gentleman, this patient came to me where the surgery was done somewhere else. Mobile bearing knee was done. 6 months post-op, bearing subluxation on the right side. probably improper positioning of the femoral component, edge loading, everything that we discussed in last 15 minutes, 20 minutes is there on the right knee, and we can see an early failure. And this can happen when you are using the manual instrumentation. Progression to the lateral compartment, that's again the problem. So again, if you see the slide on the left, here, we see that there is too much overloading, too much resection here, and it has caused early premature wear of the lateral side. A lateral uni not properly performed, the medial side is gone completely. And here, there is a too deep medial cut itself. So a large poly here. Fortunately, there is no overload here, but I'm sure this is something that is going to give a problem in near future. So all these things can happen in when you do a manual instrumentation. So technology, what is
They can also happen if you use a robot.
Oh yeah, of course.
We know all those pictures of cars standing in the water or being stuck in an alley or because somebody just followed navigation. And didn't keep the brains in on.
Correct. So if I say, when we talk about the experienced surgeons, the previous two slides that I showed, they were all done by very high volume uni-compartment knee replacement surgeons. So still in their hands, an error, surgical error like this can happen when they are doing it manual instruments. So let's see about the technology of robotics, implant positioning. We've probably covered, Ravi and Mukesh, they have covered quite, well in their talks that implant positioning, how it's going to help. But can you just say a couple of lines again for, you can cover up on the implant positioning, how it affects how better you got in using the robotics?
The implant size is almost 99.3% predictable.
Right.
So in robotics, especially image-based robotics. So that itself makes us inventory small, and also it helps in an appropriate sizing. And coming to the position, also the software gives a lot of like you can rotation and all are quantifiable. So there's a more value added advantage in implant positioning in robotics when compared to, and it's been proved also.
Yes.
The sizing may sometimes go one up and one down depending on how accurately you map or not. But as far as component positioning is concerned, in coronal plane, you can put it in a degree of varus. In rotational wise, as well as in the axial plane, you can play with a degree of slope and all. So positioning has definitely improved. Sizing may sometimes go one up and down depending on your mapping.
Right. Now, there is also a talk about the medial and the lateral joint, how you open up your medial joint space and whether it matches with your lateral joint space. That is what is going to decide the ultimate long-term survivorship of the implant. How do you make sure that when you're doing a medial UKR, that your joint line on the medial side and the lateral side are matching with robotics? Because that's probably not possible in the manual.
So it's also not, I think, possible to exactly match because the joint line is not parallel, it's oblique. So you have to see that you retain that post-operative varus. So the joint line should be convergent medially, not parallel and not laterally at all. So they should be convergent medially.
So you mean a slight undercorrection of the deformity,
always
leaving it
should
in
be.
a degree or two of varus.
3 to 4 round, so that there is joint line obliquity.
So that how much varus would you accept? 3 or 4 degrees would
3
you
to
accept?
4 degree post-op.
Right?
Yes.
Any issues with that particular figure? 3 or 4 degree varus in the tibia?
Yeah,
Not in the tibia,
not in
overall,
the overall
HCAP.
alignment.
Overall HCAP.
Okay. Right? Dr. Desai, you are in a process of getting a robot, I know. So how do you think that this is going to change?
We have it, but I haven't used the uni robotic.
Sure. Right. Okay. So we've also discussed about imageless and image-based system because I think so Ravi is using the image-based system and you're using imageless system. So we've seen the advantages. Again, let us know about the advantages of this image-based system. Ravi?
Image-based system gives a lot of pre-operative information in terms of planning. And also it's a double check with live anatomy, with CT anatomy, which is superimposed, and the final gap capturing and alteration of the implants is quite predictable. Image-less, I have not much knowledge, only theoretically I know you can answer.
I think, sir, it's individual, whatever system you have. I think it doesn't make much difference in your execution. Because after doing image also, you have to take all the points intra-op, to match and tell the computer that you are want to do this. So it doesn't make much difference whether it's image or less or image based.
Okay. So it doesn't.
Yeah, pre-operative planning will be an additional advantage in image based.
Image based.
Yeah, pre-operatively you know what size you are using. Majority of the points you know, except the bony registration and bone cuts. I mean, most of the things you know before the surgery. That's the greatest advantage in image based.
Right. Yeah. Okay. Right. I think so. We'll quickly move on to the other. So okay. So this is one of the particular publication that I came across, which showed the advantages of robotic assisted surgery. It shows there are some modifiable factors, and that is, these are the ones which can be modified very well with the robotic use of robotic technology. Number one is the implant position that we have discussed, balance of the soft tissues and getting the correct balance on the medial and lateral side, getting the joint space equal on both the sides, overall limb alignment, and proper implant sizes. So these are the things which are variable, and this can probably lead to a long-term success of UKR surgery. Another publication, alignment and balancing is 98% accurate in robotic surgery as per this particular publication, as per the preoperative plan. Navigated UKRs around 70% accurate, and manual UKRs were less than 45% accurate as per the pre-op planning. So this particularly shows the advantage of robotic technology in getting the alignment right and the balancing right. Now, whether that would lead into a good long-term results, that we don't know. So what do you think by doing all this? Michael and Mohan, just answer this first, that you are still doing the manual surgery. How is it in terms of short-term and the long-term results, your manual surgeries?
Manual surgeries, there is such a variability, especially in the UKR. I think the robo is going to help, because every time you do it, it will be executed as per the pre-op plan. So all the knees would look alike. The alignment and precision would certainly improve, I think, that especially UKR.
I'm just going to answer you the question you had before. What do I hope the robot's going to do to me? I hope I have less outliners. There's some of the pictures, post-operative radiographs, you look and you're not really happy. Usually the patient is really happy. And the patient comes and loves you and you feel bad about yourself. But I think I'm going to be more accurate and have less outliners. And we know the results are not that different.
Right, okay. So, Ravi, anything?
Nothing.
Same? Okay. Yeah. So quickly we'll go to this. These are all midterm follow-ups and they all are doing reasonably well. So again, the same publication, accuracy in hands of high volume surgeon would increase by using the technology. Amongst the beginners, they would be able to accurately hit the preoperative plan more consistently. So this is for both the experienced and inexperienced. Inexperienced means not someone who is starting with the UKR today, but someone who's done the manual surgery, UKR, and then he wants to get onto the robotic surgery. He may not be a high volume, but still they will consistently be able to hit the target. Survivorship, currently there is no difference, but long-term studies over a period of 10 years plus, they will tell us that doing all this using the robotics will help survivorship of the UKR and increase our rates of doing UKR. So I think so we'll leave it at that, because there is already, we've crossed the time, and I'm sure in clinical practice there is still a lot of use of this robotic surgery and technology. We all have to learn this, the manual and then the robotics, and see the advantage for it. Thank you very much, panel. Thank you very much for our audience. Any questions from, yes, go ahead. One or two questions can we take, Dr. Bagaria? Okay, yes. Yeah, young patient, AMOA with lax ACL.
ACL, yeah. What is the choice of treatment?
Right.
So young means age less than 40.
40?
High tibial osteotomy.
40 preservations.
High tibial osteotomy. Is there anybody who has done medial plus ACL reconstruction as well?
Not done, but at 40, I won't be doing it also.
So go for high tibial osteotomy then.
So it depends on whether that patient has tibia vara or not, because if it's in a neutral alignment.
ACL reconstruction with osteotomy.
Yeah.
It is in neutral alignment.
Similarly, at 70, 75, we see a patient who is all okay for a uni. But how many of you guys would do a uni? Because in our scenario, there is a financial constraint as well. So you can we always think, okay, better to give a total knee replacement, which will survive for 20, 25 years.
75 is the ideal, if it's the ideal candidate for the uni,
Uni,
it is very much advantageous for two reasons. One is that will be a final surgery for that patient.
Correct.
And with the least comorbidity, he will have some cardiac problem. We don't want to do a more morbid surgery of TKR. So I would certainly do
That's really great, but once the patients will have some pain, they go to another surgeon, then juicing will happen.
Different,
always.
It's a different thing altogether. That's our professional, how we handle this patients professionally, and our professional etiquette towards that. If we see a good surgery and still the patient is painful, tell them that it is going to be painful for 3 months, 4 months, 6 months. It happens in everyone's practice. So rather than undermining a surgeon or a procedure, which otherwise is a fantastic procedure, we should discipline ourselves in that.
But at 75, be careful in indication: fatty females, big BMI, osteoporosis.
Yes.
Don't do that.
I think age isn't the problem, but the bad bone might be the problem. So look at the bone.
Would you do a bilateral together, unis?
All not only about procedure, whether patient really fits. Very stringent indications in old age, little extended in younger age.
See, there are Oxford criteria that if you follow, it probably increases your indication. So you apply your mind that if you can do a bilateral uni in an old patient who actually is, he requires, you can do it. We all do bilateral TKRs where we perforate the medullary cavity and all that, bilateral. Here we are not going to do anything of that sort. So it is much, much less morbid, and it is one and the final procedure most probably for that patient who is 75. Dr. Londe.
I say the unicompartmental knee replacement, the concept is very attractive, I think. But why is it so that in India, as well as in US, I think in Europe, they are doing a lot of unis. Why it is not picking up the rate of growth?
Right.
Why the surgeons are not adapting it? Are they timid or what?
Can I answer?
Let Ranawat answer it, yes, and we all will do it.
No. What happened was,
Because there is a big divide between Europe and US.
the
Right. About unicompartmental.
See that total knee replacement are done by many who are trained, but uni was also done by sports people also. There is overlapping, and as in one of the conferences, Dr. Anil Ranawat said, okay, we were not as talented as my father, and we started doing it in the Oxford, and we had very high failure rate because we were orthoscopy surgeons, sports medicine surgeons. Maybe that may be the reason.
So last comment on this from Tanna sir and Dr. Modi sir. Okay, why this particular technology is not being picked up by many surgeons?
US is so big, you only get one Anil Ranawat to represent the whole US.
Sir.
I am at the age of 83.
Yes.
I had a uni which I have forgotten completely.
That's the reason I got you up, sir.
I am dancing around, I am doing everything. So don't blame uni for something. I think as beautifully they have mentioned, if the bone is good,
yes,
you can do uni.
That's the reason I got you up, sir, that I know you had a successful uni. We have your videos of dancing in Vyrock. Dr. Modi, please.
Somebody said, I don't know who and when, but he said, if a procedure is good, then people will go to the forest to get it.
Okay.
The fact that it is not accepted means the procedure is perhaps not as good, as simple, and it requires longer hours or longer period of study.
Sure.
That is why it is not as popular as a total knee, which is much simpler and forgiving than uni.
It's a robust procedure, robust elder brother who is standing next to a uni, and that's why uni probably is undershadowed, I think. So that's what I feel. I think so we'll close at that. And thank you very much, TTJR, for this opportunity. Thank you for audience participation.
So all good things must come to an end. So we come to an end of the academic program, but there are 2 workshops remaining after the lunch. So please join us. But before you go, just hang on. There are a few award announcements, and we have had brilliant people asking questions, debating. So it's unfair not to give an award. And I'd like to invite Dr. Tanna and Professor Wolfgang Klauser, along with Dr. Nilen Shah and Ashok, who are there to announce the awards. Please join us here. So it's very interesting, and audience are the best barometer for any popularity. So I think we had to listen to them. So the Audience Choice Award for the speaker goes to Dr. Oliver Marine. Oliver, are you here? Okay. Yeah, he's taking all the, yeah. So till the time he comes in, may I ask Dr. Nilesh to say a few closing remarks?
Firstly, thank you everybody for being here. A program is not possible unless the faculty participates, and more than that, unless quite a large number of delegates come. So thank you very much. There have been a few shortcomings in this conference, and we will try to address them so that we can come bigger and better next year. Thank you.
So Oliver is still not in here. Is Oliver here? Yeah. Okay. So the second award is the question of the day, and it goes to Dr. Sunil Dachepalli. We had two very popular choices. Dr. Karthik, is he there? He was the second best, but the best one went to Dr. Sunil. So Sunil, please come over. He had asked multiple questions. What's your favorite question that you asked, you think? Yeah. No, that's the beauty, because he is quite interactive. So, yeah. The best question. Yeah. So the next was the face-off, the debate award, debate of the whole thing. And I think unequivocally the award went to the team of Dr. Suhas Masilmani and Peter Kran. Suhas, I believe, is not there. So I think their best debate was the alignment. I think TTJR is about, a lot of it is about alignment. So Peter, will you receive the award for your team for being the best face-off, guys? You can give the award. And then we had good papers as well, which didn't happen in the main hall, but happened in the adjacent hall. And the best paper has gone to Dr. Shirish Padhe. Dr. Shirish, please join us. And I would also like you to tell us the title of your award paper, please.
So I had presented the paper on effect of posterior cruciate ligament release in the flexion and extension gap balancing during robotic assisted TKA. We had used a Mako Striker robot, and we had found result that the gap opening is more in flexion rather than in extension, and it is asymmetrical, that the medial gap opens more than that of the lateral gap. That was the finding of our research.
Thank you so much. Congratulations for visiting the best people. Yeah, so Dr. Tanna would give you the award for the best paper. So the Real Madrid. Yeah, so Oliver, well done. You have won the Audience Choice Award for the speaker for your fast track thing. You have pushed everyone into the fast track mode. So very well done. Everyone believes that you should deserve that award. Please do come.
Put in the coconut.
Coconut, don't take in your carry-in baggage, otherwise you'll be deboarded.
Oh, yeah.
Okay. Thank you. The best poster goes to Dr. Avinash Upadhyay. Well done, Dr. Avinash. And would you like to just give us the title of your...
Yeah. So I had presented a poster on case of femoral broach fracture during total hip arthroplasty. So we had encountered a case in which the broach at the trunnion was fractured during extraction of the broach. So I presented a unique technique by which we were able to extract that broach. So the brooch had a hole in the Smith and Nephew brooch had a hole in the near the shoulder of the brooch. So the brooch was implanted in the near the metaphyseal area, the hole. So then we made a cortical burr near the hole, and then using a Kunstler nail extractor, we were able to successfully extract the brooch. So this I had presented.
Well done. Please. Ashok, would you please like to? Well done. And last but not the least, we also encourage innovation when we have this. And as I said in my talk, that one of the reasons why these meetings are important is to network and we get to know new people, new development. And that's why we had a Best Innovation Award. Many of the things were not presented here, but were discussed over dinners. So it's my pleasure to invite one of my seniors, Dr. Murli Podwal and Dr. Vikas Jain, to be given the Best Innovator Awards. I learned they're doing a lot of good innovative work in the city of Mumbai. So the pair deserves a warm applause. So Dr. Vikas is involved in a lot of 3D printing work, and Dr. Murli is probably the champion orthopedic surgeon who knows more about AI than the entire intelligence of the room on that field. He works now full-time with TCS, and he has got his own company for 3D printing. So both orthopedic surgeons, but have chosen a path which is completely different and innovative. Please. And we'll also acknowledge our MMC observer, Dr. Rajesh Dharia. Thank you, sir, for giving the award points and ensuring that is there. Thank you, acknowledging you. Thank you. Thank you. So, thank you, everyone. Join us for lunch. And I think Sakshi has also done phenomenal work. So many people have done so much phenomenal work. I can't name each of you, and that is why Sakshi has put it across in a video where everyone who is in the video and not there in video also is acknowledged and thanked for. And last but not least, our sponsors also. I would like to acknowledge the role of the sponsors, the Depew, Zimmer, Smith & Nephew, and QS Beryl, who helped us immensely in organizing this, without which we can't do anything. So thank you very much, all the guys. And I'll leave you with this short video from Sakshi. She's put in a lot of effort. I had not had a chance to look at the video myself. So please pardon both of us in case there are some misgivings, some photographs that you don't like, or you would not have liked to go in public domain. Really apologies. Okay. Thank you, guys. And after the video, please do join us for the lunch. And don't forget the workshops. There are two very interesting workshops by Smith & Nephew and Merrill. And please take an advantage of the systems being there. Music, please. been an honor and privilege for all of you to be here. Thank you. Thank you. Thank you.
Thank you very much for the invitation.
Before.
Thanks again. Thank you for me. पहिली बार हो रहा है इधर एक जगह प्रॉब्लम Thank you so much. Thank you so much. Thank you so much. Thanks for doing my nose.